Okay, so welcome everyone to the fifth lecture of Carbohydrate Step 1 for the new batch of students and the free lectures. Thank you so much for joining our class. Hope you guys are doing well. If you guys can hear my voice, can I get a yes in the chat box, please? Okay, you guys can hear my voice. Good morning. Thank you so much. And can you guys see my screen? Yes or no? Okay, well, good, very good. So while we wait for the others to come and join, can we do a quick revision and recapitulation of the topics from yesterday for the next 10 to 15 minutes? Yes, is everyone ready? Okay, so let's do a quick revision and recapitulation of the topics from yesterday and the days before. So let's begin. You have a patient who comes to you with symptoms of symptoms of hypertension, hypokalemia. The patient does not have um, it's a male patient, but the patient has ambiguous genitalia. Okay, so this is a two-part question. The first part is, which enzyme is deficient in this patient? It's a young child, a young male child. The genotype is 46XY. Very good. 17 hydroxy. Okay. Now, the next part of the question is, which of the following aldosterone, cortisol, and adrenal androgens, out of all three of them, I need this answer from only one student. Can I ask this to, is anyone interested for active participation? Please write me in the chat box. I only need one student to answer this. And the student has to unmute themselves so the rest of the students can hear the answer. Who's confident they can answer the next question? Anyone? Is anyone confident to answer the next question? The next question is, what will be the level? Okay, so Dr. Nazar, thank you so much for helping us out. Would you be kind enough to unmute yourself so that the rest of the students can hear the answer?
Okay, I have already unmuted.
Okay, thank you. Now, you have a patient with 17 alpha hydroxylase deficiency. The next part of my question is, what will be the level of aldosterone, cortisol, and adrenal androgens? Will it be increased or decreased? So let's start with aldosterone. Will it be high or will it be low?
The level of aldosterone will be high.
Very good. What will be the level of cortisol, high or low?
The level of cortisol will be low.
Very good. Thank you so much. What will be the level of adrenal androgens?
Androgens also will be low.
Very good. Thank you so much. I really appreciate your answers. That's that. Let's move on to the next. Let's move on to the next question. You have another patient who comes to you with signs and symptoms of polyuria, excessive thirst, with a history of obsessive compulsive disorder. What is your provisional diagnosis? Fast answers, please. SIAD. In SIAD, if it was excessive ADH secretion, then the patient will not have polyuria. So it's not SIAD. It should be either. Very good. The answer is, since the patient has a history of a psychiatric issue or a psychiatric problem, the patient already has polyuria. If we take the history of the patient, then we would see that the patient is drinking excessive amount of water. So your provisional diagnosis should be psychogenic polydipsia. My next question is, after water restriction for this patient, you see that the urine osmolarity and the serum osmolarity remains unchanged. In this case, what is your provisional diagnosis? DI, very good. And if I add desmopressin and we have correction of the osmolarity, then what is your diagnosis? Very good. Okay. Next one is, you have another patient who comes to you with signs and symptoms of abdominal pain, hyperglycemia, glucose levels at the 450. The electrolytic findings appear in the sort of the sodium is 145, the potassium is 5.3, chloride is 100, bicarbonate is 8, and the patient also has sort of breathing where we would say that the breathing is increased in terms of the respiratory rate. What is your professional diagnosis for this patient? DKA? Yes, absolutely correct. Very good. What happens in this patient in terms of electrolytic imbalance? Is this patient hyperkalemic, or actually there's depletion of total body potassium? Which one's the correct answer? Depletion of total body potassium. Can anyone explain why we have depletion of total body potassium in diabetic ketoacidosis? There are two reasons for depletion of potassium in diabetic ketoacidosis. Can anyone tell me the two reasons? As a matter of fact, there are three reasons, not two reasons. No, two reasons. My apologies. Okay. Number one is intracellular potassium shift. Very good. So potassiums will shift. Very good. Transcellular shift. That's number one. Number two is urinary loss. Brilliant. Thank you so much. Okay. What is the reason for possible hypokalemia in hyperosmolar hyperglycemic state, not diabetic ketoacidosis? What is the reason for having hypokalemia in hyperosmolar hyperglycemic state? Polyuria osmotic diuresis. Yes, that is correct. Thank you so much. Okay. Okay, you have another patient who comes to you with a thyroid nodule. Under histology of the thyroid nodule, you see empty appearing cells, where empty cells with absence of nuclei. What is your diagnosis? Very good. Papillary thyroid carcinoma. You have another patient who comes to you with a thyroid nodule. You see under histology that the cells are normal follicular cells, but there is absence of capsular intactness. The answer is, what is your diagnosis? Follicular. Very good. You have another patient who comes to you with another thyroid nodule, FNSE. You find that there is staining of amyloid stroma under Congo red stain. What is your diagnosis? Medullary. Very good. You have another patient who comes to you with a thyroid nodule under FNSE. There are normal follicular cells, but the radioactive iodine uptake in this patient is comparatively high. The radioactive iodine uptake in this patient is high. The patient is hyperthyroid. What is your diagnosis? Thyroid nodule, hyperthyroidism, and high radioactive iodine uptake. This is an adenoma. Very good. Thyroid adenoma. Or if I tell you that the radioactive iodine uptake is not diffuse, it's only in one place, something like this. For example, for the hearings, this is the thyroid. The radioactive iodine uptake is only in this portion, in only one portion. But then what is your diagnosis? Okay, how about the uptake is like this? Instead of this, it's this. This is how the uptakes are. Then what is your diagnosis? This is a multi-nodular goiter. Thank you so much. This is a toxic multi-nodular goiter. Okay, so that's that. If instead of a nodular uptake, if the uptake was completely diffuse, then what would be your diagnosis? Graves' disease. If you have a pregnant patient who is hypothyroid, the patient is taking levothyroxine, which one will cross the placenta? My next question, will levothyroxine cross the placenta? Or if a patient has TSH receptor antibody, will the antibody cross the placenta? Which one is the correct answer? The mother is hypothyroid. The mother is hypothyroid because the mother has TSH antibodies, and the mother is taking levothyroxine. So either one will cross the placenta. The answer is very good. Okay. So levothyroxine will not cross the placenta because levothyroxine cannot cross the placenta very easily. Since the mother has TSH antibodies, the antibodies are very similar to the structure of the antibodies are basically more readily available to cause the placenta. So the answer is TSH antibodies. This is a very high yield step 1, step 2 CK question. Please remember this. My next question is if the mother has been taking levothyroxine during her pregnancy, are we supposed to increase the dose of levothyroxine or decrease the dose of levothyroxine during pregnancy? The answer is increase the dose. Can anyone explain why? Can anyone explain why? Increased metabolism? Nope. Yes, Dr. Rafiq is absolutely correct. The answer is increased TBG. By that, I'm pretty sure Dr. Rafiq is trying to say that the thyroxine binding globulin will increase. And the reason why thyroxine binding globulin will increase in pregnancy is because estrogen, that's because estrogen is increased in pregnancy, and estrogen will stimulate the production of thyroxine binding globulin. It will bind to the free thyroxine, and it will make the free T3, T4 inactive. Okay, next one is you have a patient who comes to you with bone pain, and when you study the bones of the patient, you see that there are cystic lesions with brown fibrous tissue. What is your provisional diagnosis for this? Cystic lesion with brown fibrous tissue. What is your provisional diagnosis? OFC, very good. OFC stands for osteitis fibrosa cystica, right? Thank you so much. We have another patient who has renal disease and also bone pain. What is the reason for the bone pain? What is the name of this condition where the patient has bone pain because of the renal disease? The name of this condition is? Anyone? Renal osteodystrophy. Very good. Okay. Okay. So that's basically what I was trying to say. Okay, now the next thing is you have a patient who comes to you with hypertension, hyperglycemia, excessive weight gain, moon phase, buffalo hump. What is your provisional diagnosis? Cushing syndrome. Very good. Okay. Can you guys, or do you guys remember this whole chart of Cushing syndrome? Yes or no? We measured the urinary cortisol, this, that. Yes. Okay. Do you guys remember this? Okay, good. Can anyone explain the chart of Cushing syndrome? And after someone explains the chart of Cushing syndrome, then I can move forward to Nelson syndrome and hopefully finish endocrinology today. Is anyone confident enough to explain Cushing syndrome chart, how to diagnose and manage Cushing syndrome? Anyone? Please write me in the chat box. Yes, Dr. BK. Thank you so much for helping us out. What is and how will you diagnose a case of Cushing syndrome?
First, we have to do 24-hour urine-free cortisol.
Okay.
Then, if it's increased, we can do increased late-night salivary cortisol.
Okay,
if both is increased, we can go for a ACTH. We can give a low dose of dexamethasone.
Very good.
If ACTH is suppressed, it's not increased. It may be the exogenous glucocorticoid or adrenal tumor. We can confirm with the CT scan.
Very good. Okay, so we can confirm with the CT scan. Okay, so if the CT scan is negative, then most
then it's exogenous glucocorticoid due to the drug.
Now let's talk about what would happen if the ACTH is elevated.
If it's ACTH elevated, we could do the either a high dose of dexamethasone suppression test, or we can do CRH stimulation test.
Okay, so let's talk about the high dose dexamethasone suppression test first.
With a high dose of dexamethasone, if there is no
Mhm.
suppression, it is a ectopic reason, ectopic ACTH secretion. We can confirm with a CT chest or abdomen to confirm small cell lung cancer or either any other tumor in abdomen.
What sort of tumor in the abdomen can
Small cell.
cause in the abdomen or pelvis? So it's a lymphoma. Okay, so certain lymphomas in the abdomen and the pelvis can
Okay.
cause ectopic
If it's
ACTH. Next one.
if it's adequate suppression, it is a pituitary adenoma. We can confirm with the MRI.
Great, thank you so much. Why do we choose to have MRI instead of a CT for the pituitary? Okay, so the reason is because MRIs are usually more diagnostic of soft tissues. Okay, so we can also do a CT scan, but it can better visualize soft tissues. Okay, next one is CRH stimulation test.
With the CRH stimulation, if it's increased ACTH, it is due to Cushing syndrome. Again, we can confirm with the MRI pituitary. There is no increase in ACTH and cortisol. It might be the ectopic reason. Again, we can confirm with the CT chest, abdomen, pelvis.
Okay, very good. I think you're more or less done. Thank you so much for helping us out. We really appreciate it. I hope everyone is just as confident as Dr. VK. Yes or no? Is everyone just as confident? If you guys receive this question in the step 1 exam, so the way that you guys will receive them is that the question will all of a sudden tell you about all of this. Let's say that the question will tell you that we have done this thing, we have done this, we have done this, and now the answer will lie over here. Okay, then the question will tell you that we have done the urinary cortisol, we have done the ACTH, it was elevated. Then we did a dexamethasone suppression test and we realized that there was no suppression. So what is your professional diagnosis? So the answer will lie over here. So the amount of questions that will be structured from over here is immense. And keep in mind that this has to be, you have to completely understand this and keep this in your mind because the question can arise from any one portion of this table over here, okay? Having said this, let's move forward with today's topics. The first thing that I want to talk about today is I want to talk about Nelson syndrome. Nelson syndrome in terms of its yield, is it high yield or low yield? The answer is Nelson syndrome is low yield, meaning that you will not receive many questions from this one. It's a comparatively easy concept to understand. Basically, what Nelson syndrome is you have a patient, for example, let's say that the patient has bilateral adrenal tumors, right? So the patient has bilateral adrenal tumors, let's say in both of their adrenal glands, they have tumors. So usually surgeons, they do not want to resect both bilateral tumors until and unless there is a possibility of the tumors being malignant. In cases of the tumors being malignant, then you have no other choice except to get rid of both the adrenal tumors. Now, what happens is, if the adrenal tumors are not there, will we have a negative feedback on the hypothalamus from the adrenal glands? The answer is no. Okay, so if we do not have a negative feedback, will the hypothalamus keep on secreting CRH? The answer is yes. If the hypothalamus keeps on secreting CRH, will the pituitary gland keep on producing beta endorphin, ACTH, and MSH? The answer is yes, that is excessive breakdown of pro-biomelanocortin. And as a result, the patients, they will have two things. So first of all, since there is no feedback from the adrenal glands, the hypothalamus will keep on secreting CRH, and CRH will keep on stimulating the pituitary glands. So isn't there a possibility that under the constant stimulation of the CRH, the pituitary glands can swell up? Yes or no? The pro-biomelanocortin portion of the pituitary gland, can it not swell up and get hypertrophy? Yes or no? The answer is yes or no. The answer is yes. If the hypothalamus is consistently stimulating the pituitary glands with the help of CRH, due to the absence of these three things, the pituitary glands will swell up, it will get hyperplastic, and it will start producing pressure symptoms. Yes. What are the pressure symptoms? The pressure symptoms are very simple. The pressure symptoms are basically, they will press on the optic chiasm, causing bitemporal hemianoxia. That they will cause early morning headaches, vomiting, and all the signs and symptoms of a pituitary adenoma. And along with this, these patients, not only will they have your bitemporal hemianopia, early morning headache, heaviness in the head, vomiting, they will also have hyperpigmentation. Okay, and if anyone is confused as to why they will have hyperpigmentation, the answer is because ACTH cannot be secreted by itself. It has to be secreted under the combination of beta endorphin and MSH. And this MSH will go and stimulate the melanins, and the patients will have increased amount of melanin production, resulting in hyperpigmentation. Where do we see these sorts of hyperpigmentations? For Usmle step 1, they usually use 2 regions, more or less, time and time again. One is in the palmar crease, then another one is in the gums, hyperpigmented gums, right? So that's that. Okay. Now, with hyperpigmentation, there could be another sort of a question. If you see hyperpigmentation and velvety plaques under the skin folds, is this due to excessive melanin production, or can this be due to insulin resistance in the different folds of the body? For example, neck folds, gluteal folds, axillary folds. What is the name of that sort of hyperpigmentation? That hyperpigmentation, the name is, yes, it's due to insulin resistance, but the name is acanthosis nigricans. Okay, acanthosis nigricans. The word acanthosis basically means, acanthosis means thickening. Okay, acanthosis and nigricans, nigricans. This is a Latin word for nigri. Nigri stands for dark. Okay, so dark, thickening skin folds in different parts of the body. As simple as that. Okay, so that's basically what it is. How will you treat an ACTH secreting adenoma? The treatment is very simple. The treatment is we have to go for surgery. Yes or no? You have to go for surgery. As simple as that. How do we approach a pituitary adenoma in terms of a surgery? Do we approach transnasally, transequadoid, or transsphenoid? The answer is transsphenoid. Okay, very simple. Okay, so we're done with Nelson syndrome. Do you guys understand Nelson syndrome? Yes or no? Very easy topic to understand. Okay. So when do we get Nelson syndrome? We get Nelson syndrome when there is a patient who has undergone bilateral adrenalectomy. Have I made myself clear? Yes or no? Okay, good. Now let's talk about adrenal insufficiency. Very, very high yield. Okay, let's talk about adrenal insufficiency. What is adrenal insufficiency? Adrenal insufficiency is basically the condition where we have decreased production of all the different types of adrenal hormones, especially glucocorticoids, mineralocorticoids. Adrenal androgens are not usually very, very effective in adrenal insufficiency. The reason being is because although the zona reticularis is not producing enough dihydroxyepiandrosterone and androstenedione, because of the adrenal insufficiency, we do have other organs and glands in the body that are responsible for the production of the sex hormones, such as ovaries and testes, that will take over the sex hormones. So patients will not get sign symptoms of absence of realization. So the sex hormone levels in the body will remain normal. The hormones that will get affected under adrenal insufficiency most commonly will be your mineralocorticoids and glucocorticoids. Okay, have I made myself clear? Yes or no? Now, what is the most common cause of adrenal insufficiency? Very easy. The answer is, if it's a patient from your Western world, for example, if it's from a developed world where tuberculosis is not very common, the most common cause of adrenal insufficiency is autoimmune adrenalitis, right? Autoimmune disease and autoimmune adrenalitis, where the body's T cell and lymphocytes go and attack the adrenal glands itself. And if the patient is more or less from a developing world, we still cannot rule out autoimmune, but we have to consider tuberculosis. Tuberculosis is very high yield for causing these adrenal insufficiency. So that's that. Now, over here, what are the different sorts of clinical features that we can accept, that we can expect from a patient of adrenal insufficiency? For your step 1 examination, they will basically tell you that you have a patient who comes to you with sign symptoms of excessive weakness. Okay, the patient will have sign symptoms of weakness, fatigue. Okay, so whenever we get a clinical scenario of lethargy, weakness, fatigue, okay, there are two things that should immediately come to your mind. One is anemia, another one is adrenal problems, right? Adrenal insufficiency. Now, these are the two provisional diagnoses that should immediately come to your mind. Next one is in anemia, we have weakness, lethargy, fatigue, but we also have another clinical feature. Another clinical feature that we usually see in anemia is dyspnea on exertion, right? Or pallor. Very good. But over here, there will not be any pallor, no dyspnea on exertion. Everything will be okay. But the patient will have another very high yield clinical feature. This high yield clinical feature for adrenal insufficiency is orthostatic hypotension. What does this mean? What is orthostatic hypotension? Orthostatic hypotension is basically depending on the position of the patient. For example, let's say all of a sudden, when someone stands up after sitting for a long period of time, right? When someone stands up after sitting for a long period of time, in a normal human with no adrenal insufficiency, there is vasoconstriction of the peripheral blood vessels, which does not cause peripheral pulling of blood, right? Why? Because the sympathetic activities work properly under the permissive action of what? Under the permissive action of cortisol, right? Because as we all know, cortisol, they increase the alpha-1 receptors in the blood vessels, and which allows the sympathetic neurotransmitters to work more efficiently. So if we do not have cortisol, then the alpha-1 receptors at one point, if we do not have cortisol in the case of adrenal insufficiency, then the peripheral blood vessels, there is a slight down regulation of the alpha-1 receptors due to the absence of cortisol in adrenal insufficiency. As a result, when patients of adrenal insufficiencies, when they stand up all of a sudden after sitting for a long period of time, there's excessive or increased peripheral pooling of blood, resulting in hypertension and sometimes dizziness. The patient can also have slight syncope. Have I made myself clear? Yes or no? Okay. Now, another high yield clinical feature. Please keep in mind that I use blue and red. Blue is because these are non-specific clinical features. Red is because this is very specific. Next one is another very specific clinical feature, which you will see in a patient of adrenal insufficiency, is muscle pain and muscle aches. Okay. If you ask me why, the answer is because there is electrolytic imbalance. Why? Because mineralocorticoids are not there. As a result, patients are in a state of hypo or hyperkalemia. Fast answers, please. Patients are in a state of hypo if mineralocorticoids are not there, or hyper. Which one? Hyperkalemia or hyperkalemia? Which one? Patients are in a state of. Okay. Tell me this, aldosterone, what does it do? Does it increase the uptake of potassium or decrease the uptake of potassium? Last answer, please. Aldosterone decreases the uptake of potassium, right? So if aldosterone is not there, what would happen to the potassium level? High. If it's high, patients will be in a hyperkalemic state. Yes or no? Okay, so we will get electrolytic imbalance, muscle aches, and all of these conditions. The next thing that we will get is, since aldosterone is also not there, will we get absorptions of sodium? Yes or no? The answer is no. If sodium is not there, will water get reabsorbed? The answer is no. If water doesn't get reabsorbed, can we expect the patients to undergo weight loss due to loss of water? The answer is yes, right? So patients will also have weight loss. Another thing is patients will have a very distinctive salt craving. They will crave salty food, right? So they will have salt craving. And some patients can also complain of sugar craving, but salt craving is more potent, meaning that this is a more common clinical feature. The reason why I'm spending a little bit more time talking about the clinical features of adrenal insufficiency, because you have to make your diagnosis based on this information in your question stem. Your question stem will come regarding a patient who has come to you with weakness, fatigue, orthostatic hypertension, muscle aches, weight loss, salt craving, and you immediately have to make your diagnosis that this is a case of adrenal insufficiency. Okay, have I made myself clear? Yes or no? Yes. Will they have hyperpigmentation? Yes, they will also have hyperpigmentation. Okay. I was just coming to this one. And increased hyperpigmentation. Now, let me tell you why they will not always have hyperpigmentation. Okay. If someone has absence of aldosterone and cortisol, will the clinical features be a very acute clinical picture, or will it be a very chronic clinical picture? The answer is, if someone loses aldosterone, cortisol, the clinical picture or the patient will be in a state of an acute condition. Yes or no? Because we know that aldosterone, cortisol, these are life-saving hormones. So whenever patients lose out on these hormones, they will have excessive, they will have more prolonged sign symptoms, meaning that, I mean, more immediate sign symptoms. That is, they will have weakness, fatigue, orthostatic hypertension, muscle aches for the last, let's say, two days, right? So in this span of 2 days, the patient might come to the ER with these sign symptoms, and you have to make your diagnosis immediately. You cannot wait to see if the patient also has hyperpigmentation or not, because we know that MSH will cause increased production of melanin, and this usually takes around 5 to 6 days, or in a span of a week, right? So immediately you will not see hyperpigmentation. Eventually, if you do not treat the patient, then you will see that the patient is hyperpigmented eventually after 3 to 5 days. Have I made myself clear? Yes or no? Okay. Okay. Next one is, why do they have GI disturbance? Good question. If they have, they will have GI disturbance because of electrolytic imbalance. Right? If the patient is in a state of electrolytic imbalance, the patient is has a disturbance of the level of sodium and potassium. We know that in the GI tract, right? What happens? I'm going to talk more deeply about this when I talk about GI physiology. In the GI tract, we have what? For example, this is the bolus of food that's moving forward. We have contractions, right? And over here, we have relaxations, right? And that's how basically the food will move forward. But in order for these contractions to happen, there are these types of sodium potassium channels, right, that are working in opposite directions, something like this. I'll talk about this later. And these are channels which are dependent on sodium, potassium, calcium. Yes. So whenever we get electrolytic imbalance, we get a state of in severe electrolytic imbalance. Do we not get paralytic ileus? Yes or no? That is, the GI tract stops its peristaltic movement. Have we seen a patient of paralytic ileus ever? For example, they're present right after surgery, right? They're present in long-term admission in the hospital with electrolytic imbalance. They get paralytic ileus. The only one of the most major reasons of having a paralysis of the ileus is due to electrolytic imbalance. Okay, now, since we have talked about adrenal insufficiency, let's talk about the different sorts of adrenal insufficiency. Has everyone understood adrenal insufficiency as a whole? Yes or no? Last answers, please. Okay, good. Now, let's talk about adrenal insufficiency. There are 3 types of adrenal insufficiency. Number 1 is primary adrenal insufficiency. And from what we understand, whenever we say primary, this must mean that the problem is directly in the adrenal gland, right? That the problem is directly in the adrenal gland. And what is the most common reason? Once again, if it's in the adrenal gland, then once again, I'm going to repeat myself. In Western world, it's AI. In developing world, it's mostly tuberculosis. Okay, very good. Next one is these patients, they will have either an acute onset, okay, just as I said, they'll come to the ER in the matter of 2 to 3 days, in which they will come to you in a state of adrenal crisis. They will come to you in a state of adrenal crisis, because what is the crisis? The crisis is that there's sudden excessive loss of aldosterone and cortisol. They will cause severe hypertension. The patient can have syncope. The patient can have severe hyperkalemia, and the crisis will be characterized by orthostatic hypertension, hyperkalemia, and the thing that we are most afraid of is due to the electrolytic imbalance, the thing that we are most afraid of in a patient of of adrenal crisis is cardiac arrhythmia, right? Because why? Because the SA node, AV node, and basically the nerve transmission pathways of the heart, they are very dependent on the sodium potassium levels in the body. So especially whenever we get a patient of hyperkalemia, we need to make sure that the potassium level is corrected immediately, because we do not want to invoke any sort of cardiac arrhythmias. Okay, so I'm going to give you another piece of information over here, since we are talking about cardiac arrhythmias. If we do have a patient of hyperkalemia and we want to prevent cardiac arrhythmias, right? For example, let's say that the potassium level is actually more than 6. In that case, do we have to give a medication that will protect the that will protect the heart from having an arrhythmia? The answer is yes. Very good. Okay, what is the name of that medication? The name of that medication is, yes, Dr. Ethar has already mentioned, the name of that medication is calcium gluconate. Okay. So there's a possibility you guys might receive this. I'm not sure where they asked for this. This could have been step 1 or step 2, but it's good to have this information. Okay. Now, we kept on talking about autoimmune diseases and tuberculosis for acute adrenal insufficiency. Are we aware that there's another sort of a bacteria that is a gram-negative diplococci, mostly it can cause meningitis in young children. They can also cause a sort of adrenal insufficiency. Can anyone name the bacteria first? Which bacteria am I talking about? Very good. The bacteria that I'm talking about is Neisseria meningitidis. What sort of a bacteria is this? This is a gram-negative bacteria. Is it cocci bacilli? It's a gram-negative diplococci, right? Gram-negative diplococci, Neisseria meningitidis. What can they do? What they can do is they can cause excessive adrenal hemorrhage under the influence of septicemia. So when Neisseria meningitidis affects and causes meningitis, it can cause septicemia, it can cause disseminated intravascular coagulation, and patients can suffer from a disease which we call as WF syndrome. What is WF syndrome? This is called Waterhouse-Friderichsen syndrome. Yes or no? Have we heard of Waterhouse-Friderichsen syndrome? Yes. Yes. Okay. So what sort of a question can you expect about Waterhouse-Friderichsen syndrome? The patients will have a sign symptom, or patients will have a history of irregular sexual activity. That's one. Or in which case, Neisseria gonorrhoeae can sometimes cause septicemia DIC, but it's highly rare. So these are mostly young children who will come to you with fever, lethargy, neck stiffness, right, altered consciousness, and all of a sudden the patients develop, these young patients with meningitis, they develop hypertension, then they develop weakness, more prolonged fatigue, and increased levels of potassium. So if a patient of meningitis comes to you with this sort of secondary clinical picture, can you make your diagnosis that this is the case of Waterhouse-Friderichsen syndrome? Yes or no? The answer is yes. Okay, so please keep that in mind, because you guys will be asked about Waterhouse-Friderichsen syndrome at least around 10 to 20 times in the USMLE step 1. A very high yield Waterhouse-Friderichsen syndrome. Second thing that I want to talk about is, after we are done discussing secondary primary adrenal insufficiency, I want to talk about what are the reasons and causes of secondary adrenal insufficiency. Now, whenever we say secondary, do we mean that the problem is in the adrenal gland or somewhere else? Fast answers, please. The answer is the problem is in the adrenal gland, or where can the problem be? Fast answers, please. Where can the problem be? Pituitary. Very good. Okay, now let's talk about this very quickly. Okay, so in primary adrenal insufficiencies, we had problems of aldosterone deficiency, we had problems of cortisol deficiency, correct? And we also had excessive hyperpigmentation. Once again, if aldosterone is not there, patients will be in a state of hyperkalemia, hyponatremia, and metabolic acidosis. If cortisol is not there, patients will be in a state of hypoglycemia, hypotension, and hyperpigmentation will be due to the influence of MSH. Now, if we are talking about secondary adrenal insufficiency, that means that the pituitary gland is not being able to produce enough adrenocorticotropic hormone, ACTH. Yes. So since there's a problem with the pituitary gland, now if I ask you secondary adrenal insufficiency out of aldosterone and cortisol, which one will be decreased and which one will stay normal? The answer is, what would happen to the level of aldosterone? Will this be normal or decreased? Fast answer, please. Aldosterone will be normal. Very good. Thank you so much. Why? Because I'm sure you guys remember that aldosterone is dependent on angiotensin II, right? Cortisol, however, is dependent on ACTH. So that's why cortisol will decrease. So the main difference between the clinical features of primary and secondary adrenal insufficiency is that the patients of secondary adrenal insufficiency, will they have problems of electrolytic imbalance? For example, hyperkalemia, hyponatremia? The answer is no, right? Will they have hyperpigmentation? My next question. Patients of secondary adrenal insufficiency, will they have hyperpigmentation? No. Why? The patients of secondary adrenal insufficiency, they will not have hyperpigmentation. Why? Because the pituitary gland is decreasing this secretion of ACTH. And we all know that ACTH cannot be secreted by itself. So if ACTH is decreased, then so is beta endorphin and melanotropic stimulating hormone. So as a result, these three hormones are decreased at the same time. So patients will not be hyperpigmented. Okay, so that's that. Another one is tertiary. Okay, so that's all about the secondary adrenal insufficiency. So next time you get a patient who comes to you with only weakness and orthostatic hypotension, okay, you can consider that the patient can be suffering from a secondary adrenal insufficiency. You rarely get questions regarding secondary adrenal insufficiency. I'm going to tell you why. Because it's very difficult for examiners or people who are responsible for making the USMLE step 1 question. It's really difficult for them to construct a question which can direct the students and the physicians towards the diagnosis of secondary adrenal insufficiency. But sometimes, somehow they manage to still get questions through. So in those cases, if you ever get a patient with weakness and hypotension, orthostatic hypotension, but you see that the potassium level is normal, sodium level is normal, right? Then you can consider secondary adrenal insufficiencies as one of your professional diagnoses. Okay. Now, what you might get questions about is tertiary adrenal insufficiency. What is tertiary adrenal insufficiency? This is relatively more common in the US population. The reason being is because in US, patients, they suffer from diseases that are linked to HLAs, right? That is human leukocytic antigen, DPD2DR. So patients are more at risk of developing autoimmune diseases. And we know that in autoimmune disease, the first mainstay of treatment is, right? Prednisone, right? Meaning corticosteroid. So now, if someone is taking corticosteroid for a long period of time, corticosteroids for a long period of time, for diseases such as SLE, rheumatoid arthritis, sarcoidosis, and all the different sorts of autoimmune diseases that happens, isn't there a possibility that this exogenous corticosteroid from outside, which they have been prescribed, can cause atrophy of the adrenal glands? Yes or no? The answer is yes. How? Because if someone is taking prednisone from outside, what would happen to their ACTH level? Will they be high or will they be low? That's answer, please. Will they be high or will they be low? They will be low. So the pituitary glands will, especially the pro-opiomelanocortin, will decrease the secretion of beta endorphin, ACTH, and MSH, right? So if someone is taking prednisone from outside for diseases such as SLE, rheumatoid arthritis, sarcoidosis, this exogenous corticosteroid will have negative feedback on the pro-opiomelanocortin and decrease the production of beta endorphin, ACTH, and MSH. As a result, patients who have been taking prednisone for a long period of time, if all of a sudden, if they stop, that is, we call, for example, if they have a sudden withdrawal of prednisone, If they have a sudden withdrawal of prednisone, can the pro-opiomelanocortin still have decreased production of beta endorphin, ACTH, and MSH? Yes or no? Because the answer is yes. Why? Because they have been producing low amount of beta endorphin, ACTH, and MSH for such a long period of time that the sudden withdrawal of prednisone will not increase or will not cause the secretions of these three hormones from the pituitary gland, right? Let me give you a better example for this. For example, let's say every day you wake up at 8 a.m. Okay? Every day, let's say you wake up at 8 a.m. Now, all of a sudden, if someone asks you to wake up at 2 a.m. in the morning, will it be difficult? Yes or no? The answer is yes. Why? Because you're not habituated. You're not really used to waking up at this time, right? You're always used to waking up at 8 a.m. in the morning. That's that. So the same thing goes for the pituitary gland. They have been so used to secreting small amount of beta endorphin, ACTH, and MSH in tertiary adrenal insufficiency that this abrupt withdrawal of the corticosteroids, they will not increase the stimulation of the hormones. Have I made myself clear? Yes or no? Have I made myself clear? Yes. Did everyone understand tertiary adrenal insufficiency? Yes. Okay. Now, to prevent tertiary adrenal insufficiency, when we prescribe steroids to our patient, do we abruptly stop the steroids or do we taper the dose over a course of 2 to 3 weeks? We taper the dose, right? Now, do you understand why we taper the dose? We taper the dose because we want to make sure that our pituitary gland can get sensitized to the level of the prednisone in the body, and it can start increasing its production of beta endorphin, ACTH, and MSH, so that we do not suffer from adrenal insufficiency. Have I made myself clear? Yes or no? Okay. Okay. Now, did you guys understand? Can I get a quick feedback in the chat box? If not, then I'll repeat myself. This is very high yield. Okay. So basically, hyperpigmentation. In which sort of adrenal insufficiency will you see hyperpigmentation? Primary, secondary, tertiary? Primary. Very good. What would happen to the aldosterone level in secondary and tertiary adrenal insufficiency? Normal. Okay. Very good. Now, since we have made our diagnosis, meaning that if the patient comes to us with fatigue, weakness, orthostatic hypertension, electrolytic imbalance, our professional diagnosis is adrenal insufficiency, right? In the clinic. Now we have to confirm our diagnosis. The question is how? How do we confirm our diagnosis for adrenal insufficiency? And how do we figure out that the patient is suffering from primary, secondary, or tertiary? Okay, so that's that. Now, first and foremost, what are we supposed to do? The first thing that we are supposed to do is we have to check early morning cortisol. That is, we call this as AM cortisol. Okay. Keep in mind for Cushing syndrome, you're supposed to check late night salivary cortisol. You can check 24-hour urinary cortisol or 24-hour cortisol. But for adrenal insufficiency, you will check for early morning cortisol. This is a confusion which students usually cannot figure out issue. So that's that. So basically, one more time, for Cushing syndrome, you will check for late night salivary cortisol. For adrenal insufficiency, you will check for early morning cortisol. Okay. So now, when you check for early morning cortisol, you will also check simultaneously. You will also check for another thing. You will also check for the ACTH level. Okay. Or you will do an ACTH stimulation test. Okay. So let's talk about the first one, AM cortisol first, then I'll come to ACTH. Okay. Let's talk about the first one, then I'll come to the ACTH. So what happens is when you have your clinical suspicion that the patient is suffering from adrenal insufficiency, you do an AM cortisol. When you do an AM cortisol, let's say you get a result where you do not really know if the cortisol level is high or low, but let's say it comes to a lower level, that is, the cortisol is low. What is the next thing that you should do? The next thing that you should do after you check the AM cortisol and you check and you see that the cortisol level is low, we do a test that we call as we call the test as metarapin. This is called a metarapin stimulation test. Okay, so what is this drug, metarapin? So metarapin is basically a drug that will inhibit 11 beta hydroxylase in your adrenal glands. So if 11 beta hydroxylase in your adrenal gland is inhibited, then do we have the conversion of deoxycortisol to cortisol? Yes or no? Fast answers, please. 11 beta hydroxyl. If we inhibit 11 beta hydroxylase, do we have the conversion of 11 deoxycortisol to cortisol? Yes or no? The answer is no, right? So over here, okay, so you check for the AM cortisol, you also check for the ACTH, right? And after that, you see that the cortisol level of the patient is low. After you see the cortisol level and the patient is low, you have to figure out if the patient is suffering from primary, secondary, or tertiary. So for this reason, you do a metarapin stimulation test, in which you give a drug called metarapin, which inhibits 11 beta hydroxylase, and you see these sorts of clinical findings. The first one is if it's a patient of primary adrenal insufficiency, are we going to see, okay, first and foremost, let me write this, 11 deoxycortisol to cortisol. Can you guys just give me one quick second over here, please? Can you guys hear my voice? Yes or no? Yes. Okay. Let me repeat this one more time since there was some interruption. Is everyone understanding the lecture? Yes or no? Is everyone understanding the lecture? Can I get some feedback? Okay. At any one point, if you guys are confused, if you guys are not understanding the lecture, please let me know. I have no problem repeating myself. Okay. But these are some of the things that you have to understand. There's no other way. If you're going to sit for the exam and you go to the exam without understanding these concepts, that's not a very good thing that you should do. Okay. So let's talk about this one more time. How do we confirm our diagnosis for adrenal insufficiency? Okay. First and foremost, the specimen that we should take is a late night or an early morning. The answer is the specimen should be an early morning cortisol. Okay, that's number one. Number two, what is the next thing that we should check? We should check for ACTH directly in case of adrenal insufficiency. Okay, so when we check for the AM morning cortisol and the ACTH, let's say that we get number one, we get that the cortisol is decreased. If the cortisol is decreased, then our diagnosis for adrenal insufficiency is confirmed, but we still haven't figured out if the problem is primary, secondary, or if it's tertiary. So we can get a little bit of a hint from the history and physical examination. and looking at the lab findings, but we still have to confirm the diagnosis. So if we have to confirm the diagnosis between these three conditions, we have to prescribe a drug called metarafin. So metarafin is basically a drug that will inhibit 11-beta hydroxylase. Now, what is the function of 11-beta hydroxylase? The function of 11-beta hydroxylase is this will convert 11-deoxycortisol to cortisol. Okay. So my next discussion is if I draw three types of clinical pictures. Let's talk about the first clinical picture. That after giving metarafin, if I'm talking about a patient who is suffering from primary adrenal insufficiency, is the problem in the gland? Is it in the pituitary, or is it due to exogenous hormone? Fast answers, please. The answer is the problem is in the gland. Very good. So doesn't it mean that if the problem is in the gland, that must mean that the gland has decreased production of the hormones of zona fasciculata, zona reticular, zona glomerulosa, and zona reticularis? Yes or no? That there are problems in all three layers? Yes. If the problem is in the gland, shouldn't there be decreased production of it? So if the problem is in all three layers, and we know that in zona glomerulosa, we have cholesterol to pregnenolone to progesterone, then we have 11-deoxy corticosterone, aldosterone, right? And then in the zona fasciculata, we have your 11-deoxy cortisol to cortisol, right? So the reason why I'm asking you this is if the problem is in the adrenal gland, there will be decreased production of all the hormones, all the way from the entry of cholesterol to pregnenolone will be decreased, progesterone will be decreased, this will be decreased, this will be decreased. As a result, this will be decreased with primary adrenal insufficiency. So if we see a clinical picture after giving metarafin, we inhibit 11-beta hydroxylase. If we see that the 11-deoxycortisol is decreased and cortisol is decreased, can we make our diagnosis that this patient is suffering from primary adrenal insufficiency? I'm going to tell you why. Because when you have 11-deoxycortisol, when it's converted to cortisol with the help of this enzyme, 11-beta hydroxylase, and we give metarafin, if the adrenal glands are functioning properly, shouldn't there be an increase of 11-deoxycortisol? Yes or no? If the adrenal glands are functioning properly, shouldn't there be an increase of 11-deoxycortisol? I'm going to tell you why. Okay, one more time. Let's say that the adrenal glands are functioning properly, right? Now, isn't it at this level we have 11-beta hydroxylase? It functions at this level, yes or no? Fast answers, please. Yes or no? Okay. Fast answers, please. Is it at this level 11-beta hydroxylase functions properly? Yes? Okay, good. So if we give a drug that inhibits 11-beta hydroxylase in a normal functioning adrenal gland, shouldn't there be increased 11-deoxycorticosterone and 11-deoxycortisol, increased pregnenolone and increased progesterone and increased pregnenolone? Yes or no? Yes, very good. Okay. But if the adrenal glands are not functioning properly, that must mean that everything is decreased. So you will get decreased 11-deoxycortisol, you will get decreased cortico, you will also get decreased level of cortisol. But in secondary adrenal insufficiency, what will you get? In secondary adrenal insufficiency, you will get, one second, please. Secondary adrenal insufficiency, you will get increased 11-deoxycortisol and decreased cortisol. Can anyone explain why? Why is 11-deoxycortisol increased over here? I just want to make sure you guys understood this concept. Can anyone explain why 11-deoxycortisol will increase in secondary adrenal insufficiency? Anyone? Very good. Because in secondary adrenal insufficiency, the adrenal glands are functioning normally. Okay. Have I made myself clear? Yes or no? Okay. Now, the second thing that I want to talk about is I want to talk about another thing over here. Now, in secondary or tertiary adrenal insufficiency, the problem is the adrenal glands are working normally. That's okay. But what is the problem with the ACTH level in secondary adrenal insufficiency? Is it high or is it low? The ACTH level, is it high or is it low in secondary adrenal insufficiency? It's low. Okay. Now, this is where the main confusion comes. So since the adrenal glands are normally functioning, we would expect the 11-deoxycortisol to be high. We would expect the 11-deoxycortisol to be high. But since the problem is at the level of pituitary, even after you give metarapin, since ACTH is not stimulating the adrenal glands, does it really matter if you give metarapin or not? Because whenever ACTH is not there, regardless, we give metarapin, 11-deoxycortisol will be low in secondary adrenal insufficiency. Does that make sense? Yes or no? Or should I repeat myself? Should I repeat myself? Yes or no? Okay, I'm going to repeat myself one more time. In secondary adrenal insufficiency, what happens? Yes, in secondary adrenal insufficiency, what happens? ACTH is not stimulating the adrenal glands. If ACTH is not stimulating the adrenal glands, will we have decreased production of cortisol? The answer is yes. Now, if we give metarapin, we know that metarapin will only block 11 beta hydroxylase, but we know ACTH is responsible for the pathway to go down like this. So in secondary adrenal insufficiency, since ACTH is not there, will the pathway go down like this from cholesterol to pregnenolone to progesterone to 11-deoxycortisol? Yes or no? The answer is no. So if it doesn't go down like this, can we expect the 11-deoxycortisol to decrease? Yes or no in secondary adrenal insufficiency? Now, did you guys understand? Yes. Can I get some feedback in the chat box, please? Yes or no? If yes, then good. I'll move forward. If not, I'll repeat myself. Okay. Okay. Are you sure you guys understood secondary adrenal insufficiency? Because I'm only getting a handful of feedbacks in the chat box. Can I get some feedbacks from everyone if you don't mind? Okay. How do we differentiate between 1 and 2 in this case? I'm coming to this discussion, but did you guys understand everything till now? Secondary adrenal insufficiency? Okay, now let me talk about the third scenario, then I'll talk about how do we differentiate between these two conditions. Okay, now let me talk about the third scenario. In the third scenario, let's say that after giving, okay, for example, let's say after giving metarapin, if the adrenal glands are functioning normally, right? Let's say that the patient do not even have adrenal insufficiency. If we see a clinical picture like this, increased ACTH after giving metarapin and increased 11-deoxycortisol, does this mean that the patient have adrenal insufficiency? Yes or no? In this clinical scenario, does this mean that the patient has adrenal insufficiency over here? Please try to think about this for 1 second. The answer is no. Very good. Okay. So this is the case of secondary or tertiary adrenal insufficiency. This is the case of no adrenal insufficiency. Because after giving metarapin in a normal functioning human like you and me, after giving metarapin, 11-deoxycortisol will not be converted to cortisol. As a result, there will be increase of 11-deoxycortisol, And since the patient does not have adrenal insufficiency, the cortisol level, the decreased cortisol level, will have a negative feedback, right? Will have absence of negative feedback on the pituitary, and the pituitary will start producing ACTH. And this will show that the pituitary is functioning properly, the adrenal glands are functioning properly, and as a result, this is actually a patient who does not have any adrenal insufficiency. Am I clear? Yes or no? Am I clear, everyone? Yes or no? Okay. Should I repeat one more time? Okay. Okay, let's repeat one more time. Is everyone ready? Okay, let's repeat one more time. You have a patient who comes to you. Let's start with the patient. Okay, you have a patient who comes to you with weakness, fatigue, orthostatic hypotension, weight loss, muscle ache. What is your provisional diagnosis? Fast answers, please. Your provisional diagnosis is adrenal insufficiency. Now, what is the next step? How will you check for adrenal insufficiency? Fast answers, please. AM or late night? AM. What else will you check? ACTH, yes or no? Yes, the answer is yes. Okay. Then you get the level of cortisol, which is, let's say, decreased or low normal. Now, if you have decreased cortisol and low normal, and you have a patient with the same clinical features, is your diagnosis done, or do you want to proceed further? The answer is you would want to proceed further, because you do not know if this is giving you the correct information. This result is indeterminate, right? It's not giving you the correct information. So the next thing, what you do is you prescribe a drug which will inhibit 11 beta hydroxylase. The name of the drug is metarapin. Okay, 11 beta hydroxylase will convert 11 deoxycortisol to cortisol. In a normal functioning adrenal gland, if the adrenal gland is normally functioning, if you give 11 beta hydroxylase, if you give this drug that will inhibit this enzyme, shouldn't there be increased 11 deoxycortisol and decreased cortisol in a normal adrenal gland? Yes or no? The answer is yes. But if cortisol is decreased, what would happen to the ACTH level in a normal functioning adrenal gland? We know hypothalamus, pituitary, adrenals. Hypothalamus CRH, ACTH is ACTH, pituitary is ACTH, and adrenals are cortisol. It's like this, right? So over here, if cortisol is decreased in a normal human being, what would happen to the ACTH level? High or low? Fast answers, please. High or low? High. Very good. Okay. So ACTH will be high. Okay. Now, this is the first clinical step. So if a result comes after giving metarapin, if the result comes that your 11-deoxycortisol is increased and ACTH is increased. Now, my next question to you guys is, does the patient have adrenal insufficiency? Yes or no? Does the patient have adrenal insufficiency in this sort of a clinical picture? Please do not be afraid to give the right or the wrong answer. Just give us an answer and then I'll move forward. Thank you so much. The answer is no. Okay. So you have your diagnosis. The diagnosis is the patient does not have adrenal insufficiency. So doesn't this mean that you have to go for a different sort of an approach to find out why the patient is coming to you with hypertension and this? It's not very good. But let's talk about another type of a clinical picture. Okay, let's talk about another type of a clinical picture. Give me 1 second. Okay, let's remove all of this. Now, so the first one was 11-deoxycortisol is increased and ACTH is increased after giving 11-beta hydroxylase inhibitor. The second one is after, let's say you give 11-beta hydroxylase. The adrenal glands are not functioning properly due to either autoimmune or tuberculosis. In both cases, does it really matter if you give metarapin or not? Because in both cases, shouldn't there be decrease of both 11-deoxycortisol and cortisol because the adrenal gland is not functioning? Yes or no? The answer is yes or no? In primary adrenal insufficiency, the adrenal gland is not functioning. So in this both cases, 11-deoxycortisol and cortisol will both be decreased. Can anyone tell me what would happen to the ACTH level in primary adrenal insufficiency? Will it be high or will it be low? High. Very good, because the pituitary is functioning properly. So after giving metarapin, if you see a clinical picture such as this one, decreased 11-deoxycortisol and excessively increased ACTH, then your diagnosis is primary, secondary, or tertiary. Diagnosis is primary. Thank you so much. Okay, if you guys help me out with fast responses, then that will allow me to move forward a little bit faster. So thank you so much for your responses. I really, really appreciate it. I actually wait for your response because I need to understand that you guys understood this or not. Okay, so please help me out with a faster response rate. Okay, next clinical scenario. After you give 11-beta hydroxylase, let's say that right now the patient has decreased ACTH production because of, not due to the adrenal glands, because of a pituitary problems, problem. So in this patient, once again, does it really matter if the patient has 11-beta hydroxylase or not? Yes or no? Because in this condition, the 11-deoxycortisol and cortisol will all be decreased, right? And this decreased cortisol, can it invoke an absence of a negative feedback to the pituitary? The answer is no. Why? Because the pituitary is not functioning properly. So ACTH is decreased by itself. So how do you diagnose and differentiate primary, secondary, and tertiary adrenal insufficiency? In primary adrenal insufficiency, what would happen to the 11-deoxycortisol level and the ACTH level? Fast answers, please. This is a case of primary adrenal insufficiency after giving metarapin. 11-deoxycortisol is high or low? Fast answers, please. 11-deoxycortisol is high or low in primary adrenal insufficiency. Everything is decreased because the gland is not functioning. It's low. What would happen to the ACTH in primary, high or low? Because the pituitary functioning in primary, the answer is yes. ACTH is high. Okay, let's talk about secondary. In secondary, what would happen? What would happen to the ACTH level? Is it high or is it low? What would happen to the 11-deoxycortisol level? Is it high or is it low? It's low. All of this discussion is to make you understand that 11-deoxycortisol is low in primary adrenal insufficiency because there's a problem with the gland. And in secondary adrenal insufficiency, 11-deoxycortisol is low because there's a problem with the pituitary. Okay. And if we see a clinical picture, something like this, after giving metarapin, if we see 11-deoxycortisol and ACTH, if we see that the ACTH is high and 11-deoxycortisol is high, then is this patient suffering from adrenal insufficiency? Yes or no? The patient is not suffering from adrenal insufficiency. Okay. Okay, so the reason why we spend so much time is over here is because students, physicians, even me, when I started to understand this chart, this was a little bit confusing, but hopefully this all makes sense right now. If you still have questions, you can ask me right now. Do you still have questions? Do you still have any problems understanding this? If not, I'll move forward. Yes or no? Fast answers, please. Understood. Okay. Can you repeat secondary? Secondary adrenal insufficiency is basically over here. The pituitary is the main problem. So you don't really need 11-beta hydroxylase because regardless of the presence or absence of 11-beta hydroxylase, all the production of the adrenal gland, especially the cortisol level, will be low because ACTH is not, the pituitary is not producing ACTH, as simple as that. Okay. Okay, good. Now, let's talk about another approach to this test that is a bit more easier than this portion. Okay. And let's take another approach to this test that is a bit more easier than this portion. That is over here. Let's say that instead of checking for the action of the 11 beta hydroxylase, what if we directly only depend our diagnosis on ACTH? Okay. If we do this, then things are a little bit more simpler. I'm going to tell you how. Over here, for example, let's say that after you do AM cortisol and after you check for the serum and for the serum ACTH, let's say that the ACTH is high. If ACTH is high, where is the problem? Is the problem in the pituitary gland or is the problem in the adrenal gland? Last chance, please. Adrenal gland. So what is your diagnosis? Is this primary or secondary adrenal insufficiency? Primary. Okay. Next one. If ACTH is low, where is the problem? Primary, meaning in the pituitary or in the adrenal gland? In the adrenal gland. So this could be either secondary or tertiary, because we do not know if the problem is in the pituitary gland or in the or if the patient is taking steroids from outside. So in this sort of a condition, if you, after you do a sort of imaging and you see that the patient has normal brain findings and normal brain imaging, or you do a pituitary test and you see everything is okay, then is it secondary or tertiary? Tertiary. Okay. Are we clear? Yes or no? Okay, let me talk about another condition very quickly. Okay. Now, before I jump into the next topic over here, I need some fast responses from everyone. Is everyone ready? I still have to make sure you guys understood this. Patient comes to you with weight loss, hypertension, muscle aches, weakness, hyperkalemia, hyponatremia. Provisional diagnosis, fast answers, please. Provisional diagnosis is AI. Then we check for AM or late night. We check for AM. After we check for AM, we can do two things. Either we check ACTH or we check cortisol. In the cortisol level, if we give metarapin, and after giving metarapin, we see that the 11-deoxycortisol is low, but ACTH is high. This is primary, secondary, or tertiary. That's please. Very good. After giving 11-deoxycortisol, we see 11-deoxycortisol is low and ACTH is low. This is primary, secondary, or tertiary. This is secondary or tertiary. Very good. After giving metarapin, you see that the ACTH is high and 11-deoxycortisol is high. Is this normal, primary, secondary, or tertiary? Normal. Very good. And another way is to check for the ACTH level is if ACTH is high after we check for the AM cortisol and ACTH, is this primary or secondary adrenal insufficiency? Primary. If ACTH is low, it's primary, secondary, or tertiary. This is primary. This is secondary or tertiary. Are we clear, everyone? Yes or no? Out of secondary and tertiary, if you see that the patient has been diagnosed with SLE 2 years ago, the most likely possibility is this patient is secondary or tertiary. Secondary or tertiary? Tertiary. Okay. Okay. Now let's talk about another condition. Let's talk about. Okay, let's talk about Conn syndrome. Okay, let's talk about Conn syndrome. Conn syndrome is basically a disease where we have an aldosterone secreting tumor, right? So once again, we can have primary Conn syndrome. Like I'm not going to do CS. CS can make you think of corticosteroids. I'm going to write primary Conn syndrome. That is excessive secretion of aldosterone due to the fact that there is an adrenal tumor. Yes, whenever we say primary, we are basically trying to say that the problem is in the gland, the main gland? Yes or no? The answer is yes. Whenever I say secondary, is the problem in the gland? Yes or no? Is the problem in the gland or not? No. So where can the problem be? We know that the problem cannot be in the pituitary. It cannot be in the pituitary. Why? Because the pituitary does not control aldosterone secretion, right? Because aldosterone is dependent on what? Angiotensin, right? So there must be something else there that is directly activating your, very good, Dr. Midula has already given us the answer. There's something else there that is directly increasing the activity of the renin, angiotensin, aldosterone. Okay, now, if we have to understand why renin, angiotensin, aldosterone increases, then we have to talk about the fact that, for example, let's say these are the tubules, right? This is the glomerulus. Over here, you have juxtaglomerular apparatus. Over here, you have macula densa. And I'm sorry, you have macula densa over here. You have the juxtaglomerular apparatus. So what happens is, who secretes renin? Is it secreted by macula densa or juxtaglomerular apparatus? Who secretes renin? Juxtaglomerular apparatus or macula densa? Okay. Very good. So renin is secreted by the juxtaglomerular apparatus. So what is the function of the macula densa? The macula densa is, especially the macula densa will detect the level of salt and water regulation. Yes, very good. So whenever the macula densa detects that the amount of salt in the water, the amount of salt in the blood is low, or the blood volume itself is low, it stimulates the juxtaglomerular apparatus to secrete renin. And then we know what happens. Renin converts angiotensin again to angiotensin 1. Angiotensin 1 is converted to angiotensin 2, and angiotensin 2 will activate aldosterone. Okay. Now, my next question is, in secondary Conn syndrome, why do we have excessive activation of the renin, angiotensin, aldosterone? And as a result, why do we have hyper secretion of aldosterone? Now, there can be multiple reasons. Number one, can there be reninoma? Yes or no? A renin producing tumor? Yes. Okay. Reninoma means that the problem is not in the adrenal glands, so it's a secondary cause of hyperaldosteronism. Next one. Can there be decreased blood supply due to thickening of the afferent arterioles? The answer is yes. If there's decreased blood supply, then that will activate. Where and how do we get decreased blood supply? This could be renal artery stenosis, either due to fibromuscular dysplasia, which is more common in women, or renal artery atherosclerosis due to excessive smoking and all of those conditions. So that's that. Can we get a tumor that is compressing on the renal arteries? Yes or no? Okay. If the tumor suppresses on the afferent branch of the renal artery, that decreased blood flow will go. So basically, are you telling me that any reason for which there's decreased blood supply to the glomerulus, this will activate the renin, angiotensin, aldosterone? Yes or no? Is that what you're telling me? The answer is yes. Okay. So no matter what, this could be a tumor, this could be atherosclerosis, it could be renal artery stenosis, this can also be reninoma, but anything that is decreasing the supply of blood to the macula densa or increasing the production of renin due to a reninoma will cause secondary hyperaldosteronism. Are we clear with this? Yes or no? Yes. Okay. Now, what would happen if there's a patient suffering from hyperaldosteronism? Can we get a clinical picture where the patient comes to you with signs, symptoms of hypertension and hypokalemia, hypernatremia? Yes? Okay. So next time, the clinical picture, if you get a patient who comes to you with hypertension and hypokalemia, can you make your diagnosis that the patient is suffering from Conn syndrome? Yes or no? Fast answers, please. Yes or no? Okay, good. Okay, so with that being said, can we take a break for 5 minutes to replenish our neurotransmitters in between the synapses? Every time I take classes on adrenal insufficiency, it's more it's more of a torture than it is taking a class, because it takes a toll on me, because it's very difficult to explain the metabolism part of the it's actually very difficult to sort of talk about the metabolism portion. But having said that, did you guys understand the metabolism portion or not? If you didn't, then I have no problem repeating myself. Did you guys understand the metabolism portion? Okay, how about this? Can I repeat the metabolism portion again? Okay, so I know you guys understood this. You guys are absolutely brilliant students. I really appreciate your concentration in the class. So just to make sure that we still understood the metabolism portion of the ACTH part, we will repeat this after the end of the class, okay? We will repeat the whole thing after the end of the class, because if I keep on repeating the thing again and again, then I will not be able to move forward. So today, after the end of the class, we will do the ACTH and the metabolism thing one more time, okay? So let's take 5 minutes and to sort of replenish our neurotransmitters, drink some water, coffee, whichever, and then let's come back and let's talk about neuroendocrine tumors, very important, neuroblastomas. And I'll also sort of go through the text over here very quickly, and I'll tell you exactly what you need to underline for questions. So that next time when you study the first data, it will be easy for you. Okay, so thank you so much. Let's take a 5-minute break. Okay, is everyone back from their break? Yes or no? Is everyone back from their break? Can you guys hear my voice? Do you guys like watching baby videos on YouTube? Funny baby videos? Yes. One of the best pastimes. The best things that I do for the whole day after getting a little bit tired, I go through the videos of babies doing funny things. Yes or no? Do you guys like watching funny baby videos or not? No, no one likes babies. Okay, no one's a fan of babies. Okay. Okay, so we have one fan of baby videos. So look at this baby over here. Do you see anything that's different with this baby? You have two babies. Congratulations. Very good. Okay, now let's look at what happened right now. Please tell me if you notice something in the video. Did you guys notice anything? Yes or no? Did you guys notice anything in the video? Okay. Very abnormal movement, right? You guys notice the myoclonic jerk over here. Look at the myoclonic jerk. Yeah, you see that little jerk over there? One more time. Yeah. So that's called the myoclonic jerk. So I want to talk about another condition that I want to differentiate this condition with myoclonic jerking with this sort of ataxic condition. Okay. This is a young child who is suffering from a disease which we call as dancing eyes and dancing feet. In other name, we also call this as opsoponous myoclonic syndrome, which is directly related to a neuroendocrine tumor, which we will talk about in 1 second. Okay, I want to show you the video first. Let me know if you notice anything. So what do you guys notice about the eyes? Look at the eyes. Okay. Okay. So a sort of a dancing eye, nystagmus like movement of, and over here, let me show you another video of a young woman. So we're seeing jerks. We're seeing abnormal movement of the eyes. What else are we seeing over here? Okay. Okay. Look at what's abnormal with this young woman over here. Okay. Do you guys notice the hands? Look at the hands. This hand. Look at the tremor. Okay. So that's that. Now, having said this, what am I trying to say over here? Let's talk about this. Fidgety hand movement. Yes, that's very good. Okay. So what's happening over here? So first and foremost, we're talking about neuroendocrine tumors. Okay. So first of all, we're talking about neuroendocrine tumors. Okay. So whenever we talk about neuroendocrine tumors, we are going to talk about cells that are the neuroendocrine cells and the tumors which they give rise to. So neuroendocrine tumors, whenever we talk about this, we have to talk about the fact that we have some neuroendocrine cells. Neuroendocrine cells are the cells where they get the stimulus to have hormonal activity under the influence of the central nervous system. That's why the word neuroendocrine means that these cells are producing hormones under the influence of the central nervous system. So neurohormone, neuroendocrine. Okay, so what are the different sorts of neuroendocrine cells? Neuroendocrine cells are basically cells that, once again, are dependent on the stimulation of the nervous system. So where do these cells usually stay? These cells, they usually stay in the GI, they stay in the pancreas, and we get one type of neuroendocrine cell in the lungs. Okay? So out of all of this, the pancreas is the most high yield for having a high amount of neuroendocrine cells. What are these cells? These are your alpha beta delta cells, right? So the pancreatic beta cells, enterochromatin cells, the delta cells, they're all neuroendocrine cells. In the GI tract, do we have neuroendocrine cells? The answer is yes. Cells that are responsible for the secretion of gastrin, such as the G cells, right? They are the neuroendocrine cells. So if we have tumors of these cells, do we get increased productions of the hormones? Yes or no? Last answers, please. The answer is yes. Okay. So what happens over here? If you get a tumor of the delta cells, what sort of hormone, especially the delta cells, I mean the alpha cells of the pancreas, what sort of hormone do you think will be overproduced? The answer is glucagon, yes or no? Beta cells, it will be insulin. Then there's another type of cell that is responsible for the production of VIP. Patients can get VIPoma. Signs symptoms of VIPoma are called WDHA, that is watery diarrhea, hypokalemia, and achorrhea. And then you get tumors of the delta cells. You get somatostatinoma. These are all the neuroendocrine hormones. Then you get tumors of the G cells. Patients can get gastrinomas. And whenever patients get gastrinomas, we have increased production of gastric acid. If we have increased production of gastric acid, can we expect to see ulcers in the duodenum, jejunum, and ileum? Yes or no? The answer is yes. Always remember this for step one. If you ever get ulcers in the jejunum and ileum, think about the fact that they're talking about a gastrinoma or a gastric producing cell or hypersecretion of gastric acid. Because normally patients are not supposed to get ulcers in the jejunum and ileum. Patients can only get ulcers in the stomach normally and in the duodenum under the influence of eating habits or Helicobacter. But Helicobacter and eating habits usually will never cause ulcers in the jejunum and ileum. So whenever we get ulcers over these regions, that means it is due to a gastric producing tumor. So that's that. Lungs. In the lungs, we have another neuroendocrine tumor. The neuroendocrine cell is the small cell, and the tumor is the small cell carcinoma. Small cell carcinoma. Okay, so that's it. So having said that, I want to talk about another thing over here. I want to talk about the fact that how do we basically try to diagnose the presence of neuroendocrine tumors? Neuroendocrine tumors can be diagnosed clinically, number one. Also, they have some distinctive secretory products. Secretory product, meaning that this will give you an idea that the patients may be suffering from neuroendocrine tumors. So this is something which you have to sort of memorize and keep in mind, because these are basically your findings that you see in the labs or in the peripheral blood. So there are three things that will be present in the blood whenever we have a neuroendocrine tumor. I'm not sure if you guys have heard of this, but if you guys are from the first batch, then I'm pretty sure you did. If you guys are studying step one right now, then this should be comparatively new. These are chromogranin, my apologies, chromogranin, then synaptoplasm, and neuron-specific enolase. Okay. Neuron-specific enolase. These are the three things that will be present in the blood that will give you an idea that the patient will be suffering from neuroendocrine tumor. Sometimes when we also have a carcinoid tumors, we can also get excessive amount of serotonin, resulting in serotonin syndrome. Okay, so excessive amount of serotonin can also indicate that the patient is suffering from a neuroendocrine tumor. What is the treatment of neuroendocrine tumors? Since it's a tumor, the number one approach should be to go for a surgical approach, surgery. And the second thing is there is another type of an analog that will block the production of neuroendocrine hormones. This analog is obviously a somatostatin analog. Somatostatin analog. Okay, that is octreotide. Okay, now let's talk about some other tumors related to the videos which we just saw. Okay. Till now, we have been talking about adrenal cortex. Yes. Till now, we have been talking about the adrenal cortex. Adrenal glands, cortex, medulla. Cortex, medulla. Till now, we have been focusing on zona glomerulosa, fasciculata, radicularis. But now we will focus a little bit on the adrenal medulla. Why? Because adrenal medulla, if we have tumors in the adrenal medulla, then we can get basically get issues. So let me tell you what happens. When we get tumors in the adrenal medulla, there is overproduction of certain things. Number one is epinephrine, norepinephrine. Okay. Do you guys remember seeing the video of the little baby with the dancing eyes and that jerky movement, myoclonus? Yes or no? Okay. Now, the reason why that baby was acting like that, not the first baby, not the baby of the myoclonus jerky, the second baby, the child, the young female child. Do you remember seeing the eyes move back and forth? And also the patient was a little bit jerky. And the 23-year-old young woman, you saw that the hands were moving. That is due to the fact that those patients were suffering from a disease where they had excessive amount of epinephrine and norepinephrine. What happens when you have excessive epinephrine and norepinephrine? Do you have excessive stimulation of the postsynaptic membranes? Yes or no? The answer is yes. Okay. As a result, do you have these sorts of abnormal movement? The answer is yes. Okay. So the thing is, these patients, they have excessive amount of epinephrine and norepinephrine. In short, we say that they have excessive catecholamine activities. And catecholamine, whenever they are broken down in the body, catecholamines, especially epinephrine and norepinephrine, they produce two types of compounds or metabolic substrates. Number one is something that we call as HVA. HVA stands for homovendylic acid, and VMA. VMA stands for vinyl mandelic acid. Okay. These two things, they are excessively present in the urine. So if we suspect that the patient might be suffering from a neuroendocrine, especially an adrenomedullary tumor, okay, then if we do a urinary test of HbA and VMA and we see that they're high, then can we confirm our diagnosis? Yes or no? The answer is yes or no? The answer is yes. Okay. Okay. Even after, after seeing that the homovendylic acid and the vinyl mandelic acid in the urine, we see that they're high. But even so, since it's a tumor, we know that serology and urinary findings are not absolutely definitive. What is the most absolute definitive approach to diagnose or confirm a tumor? That is biopsy. Yes, imaging and biopsy, right? So when we do a biopsy, let me talk about the biopsy in 1 second. Just give me 1 second. Now, Adrenal medullary tumor. So we're talking about adrenal medullary tumors. Let's talk about the tumor difference in adults and in children. When we have an adrenal medullary tumor, especially in a child or in children, this adrenal medullary tumor is what we call as a neuroblastoma. Okay. What are some of the sign symptoms of neuroblastoma? The sign symptoms of neuroblastomas are the ones which we just saw right now. That is the opsoclonus myoclonus syndrome. Patients present with jerky movement of their hands, feet. Their eyes are moving back and forth, which gives you the idea that the eyes are dancing. So dancing eyes, dancing, and the feet are moving back and forth, which gives you an idea that the feet are also dancing. We call this dancing eyes and dancing feet. Another name is opsoclonus myoclonus syndrome. Okay. Another thing is that the adrenal medullary tumor neuroblastoma in children, they are very easily palpable. You can palpate them. Can anyone tell me why? Because obviously, since children, do they have a lot of abdominal mass and abdominal fat and abdominal contents? The answer is yes or no. The answer is no. So isn't it easy to palpate the tumors, especially if there's an adrenal tumor? The answer is yes. Okay. And we can we can basically come to a conclusion about neuroblastomas in children whenever we see that the tumor masses. Okay, I'll talk about the adults a little bit later. Whenever we see that the mass in the children, especially in neuroblastoma, first and foremost, the mass will be, when you try to palpate the mass, it will be firm, it will be irregular, and the mass will cross the midline. It will cross the midline. For example, let's say this is the baby, this is the baby's umbilicus. The mass will sort of cross the midline, like something like this. Okay. Are we clear? Yes or no? Okay. Okay, now that's done. So let me draw you a clinical picture. A young child comes to you with this sort of dancing eyes, dancing feet sort of sign symptom. The patient, when you try to palpate the abdomen, you find a firm, irregular mass which crosses the midline. What is your provisional diagnosis? What is your provisional diagnosis? Child comes to you with dancing eyes and dancing feet. When you palpate the abdomen, you find a firm, irregular mass that crosses the midline. What is your diagnosis? Neuroblastoma. Very good. Okay. You find that the patient is suffering from, you think that the patient is suffering from neuroblastoma. So then, are you going to do a urinary examination of HbA and VMA? Yes or no? Yes. And you find that these are high. Next step to confirm your diagnosis. Imaging and biopsy. In imaging, where will you find the tumor? In the adrenal cortex or in the adrenal medulla? You will find them in the adrenal medulla. Very good. Biopsy. Let's talk about biopsy. So you take a little bit of tissue. What do you see? You know what you see? Let me tell you what you see. You see this guy. Okay. You see this guy. Not sure if you guys are aware who he is. Okay. Did you guys hear about The Simpsons? Yes or no? Yes. Is everyone aware of the cartoon Simpsons, especially these yellow characters, this yellow cartoon characters? Look at what he does. Look at this. Okay. So Homer Simpson, this is the character. Simpsons is a very famous cartoon, which shows the family of, which shows a typical American family. And you see Homer is over here outside of a pub after drinking alcohol. He's dancing. Okay. So Homer dancing, and look at the eyes of the Homer, look at the body movement of Homer, right? Everything about this is very similar to this one. Okay, maybe not as exaggerated, but that's it. The reason why I'm showing you this video is because whenever you do a biopsy of a neuroblastoma, what you will find is you will find Homer Simpson. Homer Simpson. Okay, so I need you to remember this, Homer Simpson. Now, Homer Simpson, obviously you will not find Simpsons, but you will find our Homer Wright rosettes. Okay, now Homer Wright was the name of the scientist who basically, what he did was during his time, whenever he would find anything that was arranged in a rose-like pattern, something like this, right? Whenever he would find something in a rose-like pattern, he gave the name Homer Wright rosettes. Can anyone tell me where else can we see Homer Wright rosettes? Can anyone tell me where else can we see Homer Wright rosettes? We can see Homer Wright pseudo rosettes in a childhood brain tumor. We'll talk about this later, but it was basically the same guy. So whenever, yes, very good, brain tumor. So in a brain tumor, and as a childhood brain tumor, I'll talk about that brain tumor later. So in a childhood brain tumor, we also see Homer Wright pseudo rosettes, right? Medulloblastoma, thank you so much, right? We know that the childhood brain tumors are PNECP, that is pinealoma, medulloblastoma, ependymoma, craniopharyngioma, and pilocytic astrocytoma. Out of these 5 childhood brain tumors, medulloblastoma also has Homer Wright rosettes. Thank you so much. I'm really glad that you remember the name. No? So that's it. So Homer Simpson's, Homer Wright rosettes, dancing eyes, dancing feet. I'm pretty sure you guys can make the diagnosis. Okay. Last piece of information over here. Since it's a tumor, there has to be a genetic mutation that is involved for the development of the tumor. The oncogene that is responsible, oncogenes are basically genes that are responsible for giving rise to different sorts of tumors in the body. The oncogene that is responsible for giving rise to neuroblastoma, we call this gene as NNYC. Okay, NNYC. Sort of, it can help you. You can remember that my neuroblastoma. Okay. So in neuroblastoma, my neuroblastoma for NNYC. Okay, that's it. Are we clear, everyone? Yes or no? Okay. Now, before I move on to the text in first aid, I want to inform you guys about the questions. One more time, patient comes to you then with this sort of dancing eyes, dancing feet, form irregular mass that crosses the midline. Your provisional diagnosis is? Neuroblastoma. Very good. Okay. Next thing, you check for the urinary VMA and HVA. Will it be high or will it be low? It will be high. Next thing, you do an imaging. Where will you see the tumor? Adrenal cortex or adrenal medulla? Adrenal medulla. Very good. Next one, you take a biopsy, and what do you see? Homer Wright rosettes. Very good. Where else do we see Homer Wright rosettes? In a childhood brain tumor. Okay, I'll talk about the childhood brain tumor later. Next one is do we see chromogranin, synaptopathin, and urine-specific analyte that's positive in case of a neuroblastoma? Yes. Okay. Okay. What is the name of the oncogene that is responsible for neuroblastoma? My neuroblastoma. Very good. Okay. So we have covered a lot till now, I suppose. Let's talk about the text. Okay, first and foremost, we started our lecture today with Nelson syndrome. Over here, What are the sort of questions you will receive? You will receive questions regarding treatment. I'm going to use my blue pen to help you understand. This is not very important. Okay. And the pathology is there. It includes a mass effect. That's that. Adrenal insufficiency. Everything about adrenal insufficiency is exceptionally high yield. So there's nothing you can really leave behind. Okay. What are you going to get? Your questions will come from over here. That is with the symptoms. So whenever you study adrenal insufficiency, try to recapitulate the symptoms first. Think about weakness, fatigue, hypertension, muscle ache, weight loss, salt sugar craving. Treatment is simple, hormonal replacement. Okay, next one. Primary adrenal insufficiency. The most common questions you'll receive are the causes. So you have autoimmune and tuberculosis. Then this is basically the pathology. Questions might come from over here regarding the gland functions, right? Always remember the questions that will come is aldosterone, cortisol, and androgens. In primary, secondary. Primary, it will be low, low, low. In secondary, aldosterone is going to be normal, cortisol is going to be low, low. Okay, so that's that. Secondary adrenal insufficiency, decreased pituitary secretion. Okay. No hyperkalemia because the aldosterone being activated by angiotensin. Next one is tertiary adrenal insufficiency. That's why do we get tertiary adrenal insufficiency is also a common question because patients have abrupt withdrawal or sudden withdrawal or abrupt cessation of chronic steroid therapy. So that's that. Okay. Next one is this one. As you can see, in 2021, they have not mentioned the metarapin, but I mentioned the metarapin. The reason being is because they still have questions regarding this and boss in the new world, so you have to know about the metarapin stimulation test. Next one is Waterhouse-Friderichsen syndrome. That is bilateral adrenal hemorrhage and insufficiency due to Neisseria meningitis, which is a gram-negative diplophosphamide. That's that. It presents with insufficiency and petechiae. Always remember this. Patients, the clinical picture will be about a patient with a history of having fever, signs, symptoms of meningitis, and petechiae, which will tell you that the patient is suffering from meningococcemia. You can also expect the patient to have adrenal problems. Okay. So that's that. Let's come over here. We talked about hyperaldosteronism, increased secretion of aldosterone. It's called hyperaldosteronism. Patients will have hypertension and hypo or normal, mostly it's hypokalemia, and metabolic alkalosis will also happen. Okay. Why will we get metabolic alkalosis in hyperaldosteronism? I'll talk about this in the renal system. If I start talking about this right now, then this will be a lengthier discussion. Okay, I'll talk about this later in the renal system. But just for now, try to remember that they will cause metabolic alkalosis. Okay, second, primary hyperaldosteronism does not directly cause edema because of aldosterone escape mechanism. This is aldosterone escape mechanism. This is something which I think some of us are aware of. What is aldosterone escape? Aldosterone escape is basically when we get excessive aldosterone that increases the blood volume, it goes and it stretches the atrial muscles, resulting in the release of atrial natriuretic peptide. Atrial natriuretic peptide, what does it do? It increases natriuresis, and that's why there is in primary aldosterone secretion, this increased amount of atrial natriuretic peptide will cause natriuresis. What is natriuresis? Natriuresis is excessive urination and loss of salt and water. So this increased reabsorption of salt and water and excessive urination of salt and water keeps the normal blood volume in check. That's why we call this mechanism as aldosterone escape mechanism. This is not high yield for USMLE step 1, but this is high yield for bachelors of medicine and surgery. So that's that. I'm pretty sure you guys have received questions regarding the aldosterone escape mechanism. Yes, when we studied in our bachelors of medicine and surgery physiology, do you guys remember aldosterone escape mechanism? Yes or no? Or is this completely new information? Yes, I'm pretty sure this is a yes for everyone. Everyone learned about the aldosterone escape, but this is not commonly asked. There could be one or two questions regarding aldosterone escape where they asked about the normal physiology or if you are aware of why this happens. One more time, this happens because of the increased blood volume. It stretches the receptors of the atria and the ventricle, resulting in the secretion of AMP, BMP, especially AMP. It's responsible for causing natriuresis. Okay. Then let's move on to primary hyperaldosteronism, which is basically an aldosterone secreting tumor. Secondary hyperaldosteronism is due to either reninoma, renal vascular hypertension due to renal atherosclerosis, or fibromuscular dysplasia. Sometimes in cases of cirrhosis, heart failure, and nephrotic syndrome, the blood volume also kind of falls. And when the blood volume falls, once again, we have activation of the macula densa, juxtaforaminal apparatus, and activation of the renin-angiotensin aldosterone. So that's that. Yeah. Now, neuroendocrine tumors, we talked about this already. They originate from the neuroendocrine cells, which have traits similar to nerve and hormone-producing cells. That's exactly what I said. The neoplasms could be carcinoid, gastrinoma. And please remember, for gastrinoma, you will find ulcers in the jejunum. You will find ulcers in the duodenum, jejunum, and ileum. Okay, in all of these cases. Pancreas insulinoma, glucagonoma. For glucagonoma, one of the highest yield things you can remember is the glucagonoma skin rash. Okay, we call that skin rash as necrolytic migratory erythema, very, very high yield. Did you guys see a picture of necrolytic migratory erythema? Yes or no? Skin rash, glucagonoma skin rash. Yes. Okay, I'll move forward then. Small cell carcinoma is also a neuroendocrine tumor. In thyroid, medullary carcinoma is also a type of neuroendocrine tumor, and in adrenals, we have pheochromocytoma. That's a type of neuroendocrine tumor. Now, neuroendocrine cells, they share a common biological function through an amine precursor uptake, decarboxylase, despite differences in biological origin, anatomic site, and secretory products, meaning that all the neuroendocrine cells, they produce the hormones because they all have the same amine precursor. That is this one. So I'm going to use my blue pen for this because this is not a question for your USMLE step 1, but I feel like there is a potential that this could be a question in the future. So amine precursor uptake decarboxylase, or APUD, is basically a precursor used for the synthesis of epinephrine, norepinephrine. That's it. Okay, next one is, what do we find in the blood in the presence of a neuroendocrine tumor? This is something I'll use my red pen for because they asked this in the exam. We find chromogranin A, muon-specific amylase, synaptophasin, sometimes serotonin, histamine, and calcitonin. This is not high yield. So that's that. Whenever we get a neuroendocrine tumor, the treatments are very simple, either a resection or an analog. Now, let's talk about the neuroblastoma. Neuroblastoma is basically a tumor of the adrenal medulla. We see them in children at the age of less than 4 years of age, or it originates from the neural crest cells. Okay, please underline this. I'll talk about neural crest cells and everything else in biology, so do not worry about this right now. It occurs anywhere along the sympathetic chain. We understand that. Most common presentation is abdominal distension, firm irregular mass that can cross the midline. Versus Wilms tumor, which is a renal tumor, and it's smooth and it's unilateral. It will not cross the midline. So this is another differential. It's less likely to develop hypertension because pheochromocytoma will develop hypertension when neuroblastoma is normotensive. This is very important. Neuroblastoma will not cause hypertension. That is epinephrine and norepinephrine. In young child, they will not cause a lot of hypertension. If you ask me why, the reason being is because epinephrine and norepinephrine will not cause a lot of vasoconstriction because the receptors, alpha receptors, and everything else in young child, they're not very sensitive to the different sorts of catecholamines. That's why children will usually stay normotensive. Okay, so that's that. And it presents with optochronous, myoclonus syndrome, dancing eyes, dancing feet. Okay. Urinary tests will find that HbA BMA will be very high. This is a star. And we will find Homer-right rosettes. As you can see, this sort of rose-like pattern. Okay, Homer-right rosettes. We usually find them in neuroblastoma and medulloblastoma. Okay. It's associated with neuron-specific amylase and bombicin. This is not important. Don't worry about this. You will not get asked about this one, but you will get asked about the recent amplification of MMYC oncogene. Okay. Are we clear, everyone? Yes or no? Okay. Okay, so we're clear. Today we will finish endocrine pathology. We only have 3 more pages. Tomorrow we will talk about endocrine pharmacology. Before we finish the last 3 pages of endocrine pathology, can we take our long 15-minute break? Yes or no? Okay, so let's take a break for 15 minutes. Let's come back. Let's finish endocrine pathology and let's do a couple of endocrine questions today and see how we do. Okay, so it's 11:49 as of right now. Let's start the class at 12:05 p.m. Thank you so much. Okay, is everyone back from their break? Can you guys hear my voice? Hey. Oh, are we ready to begin the discussion? Yes or no? Good. Thank you so much. Let's begin. Okay, so far, we have studied a couple of very high yield things today. What we have studied is we have studied adrenal insufficiency. We have studied Conn syndrome, neuroendocrine tumors, neuroblastoma. The next thing that we want to talk about is we want to talk about pheochromocytoma. Okay, so that's that. Let me take a small blank page lecture on this, and then I'll move forward to the text so that we can remember all the information a little more easily. Okay, so that's it. Now, having said this, let's begin. First and foremost, what is pheochromocytoma? Pheochromocytoma is another type of an adrenal medullary tumor. Just as how we get neuroblastomas in children, we get pheochromocytomas in adults. Okay, usually adults are the ones who end up receiving or who get pheochromocytoma. Just as how neuroblastoma was developed from the neural crest cells, pheochromocytomas in adults also occurs from neural crests. Okay, so these are neural crest cells. Now, there are a couple of mutations with pheochromocytomas. Okay, can you guys name the oncogene that is responsible for causing neuroblastoma? What are the oncogenes responsible for causing neuroblastoma? Very good. That is my neuroblastoma, for NMYC. There's another disease. Okay, there's another disease. I'm going to tell you what that disease is. Let me just show you this. There's a disease called neurofibromatosis type 1. I'm pretty sure you guys have seen patients of these types of tumors, right? Neurofibromas. Yes, this is a neurofibroma. This is a neurofibroma type 1, neurofibromatosis type 1, and then we have neurofibromatosis type 2. These are basically neurodermal tumors, right? So in neurofibromatosis type 1, we get this sort of neurofibromas. We get another thing called cafe-au lait spot, leash nodules, suboptic gliomas, right? And we also get another one, that is, we get pheochromocytomas. We get pheochromocytoma in neurofibromatosis type 1. So if I have to talk about all the germline mutations in the genes that are responsible for giving rise to pheochromocytoma, the number one is neurofibroma type 1, NF1 gene. Neurofibroma type 1 is associated with pheochromocytoma. So neurofibromatosis type 1 is, once again, let me repeat this. Patients will get cafe-au lait spot, neurofibromatosis, leash nodules, and pheochromocytomas, and multiple like other things which we will talk about later when we talk about neurocutaneous disorders. There's another disease that is directly associated to the formation of renal cell carcinoma. Let me tell you the four names. We have hemangioblastomas, angiomyolipoma, renal cell carcinoma, and pheochromocytoma. Can anyone name this disease? It's an autosomal dominant disease where we have this four diseases, four conditions together. Very good. Okay, so Dr. Dahlia was kind enough to mention the name VHL. VHL stands for von Hippel-Lindau syndrome. Von Hippel-Lindau. Okay, so VHL. VHL is also associated with pheochromocytoma. Okay, and the last one that pheochromocytoma is associated with are MEN2A and MEN2B. If you guys remember anything, then I said that MEN1 is due to the presence of due to the absence of MEN1 tumor suppressor genes. MEN2A and MEN2B, where in MEN2A, we get pheochromocytoma with medullary thyroid carcinoma and hyperparathyroidism. It's due to mutation in a gene, which we call as, does anyone know? Thank you so much. It's RET. Okay, so pheochromocytomas are associated with these three genes, and this is exceptionally high yield for the step 1, step 2 CK exams. Now, pheochromocytoma, what are the sign symptoms of pheochromocytoma in an adult? The sign symptoms of pheochromocytoma in adults are very simple. Since the adrenal medulla is responsible for the production of epinephrine and norepinephrine, patients will always be in a state of catecholamine surge. What is a stage of catecholamine surge? Patients will always be in a state of fight or flight, that is sympathetic, right? So let's talk about sympathetic. First of all, we have Dr. Hagar, Dr. VK, and Dr. Jorge Otero who said hypertension, and that is absolutely correct. The first one is hypertension, patients will be hypertensive. Next one, in a sympathetic overactivity, do we get vasoconstriction or vasodilatation? Excuse me. Fast answers, please. Vasoconstriction or vasodilatation? Vasoconstriction, of course. So patients will be pale, or there will be a state of pallor because the vessels will be constricted. Next one, do we have increased rate and depth of breathing when we are in a sympathetic when we are in a sympathetic state? The answer is yes. Okay, so increased respiration or increase of perspiration. Next one is, what would happen to our pulse? Will it be high or will it be low in a state of sympathetic activity? It will be high. So patients will be tachycardic. Okay, what else? What else can we see in pheochromocytoma? In pheochromocytoma, what we can also see is that patients will have very good, thank you so much, anxiety, then tremor, then, yes, very good, Dr. Hagar, that is headache. Okay, so that's that. These are some of the sign symptoms. And this will be in a diurnal variation. What does this mean, diurnal variation? That means that the sign symptoms will come and go. Okay. For example, let's say you feel like this in the morning, in the afternoon you're okay, in the evening you feel like this again, then in the early night it will be okay, late night you'll feel like this again. So this will be in a diurnal variation, or yes, another word for this is episodic. Okay, good, very good. Next one is do we do a urinary test of VMA and HVA over here? Yes or no? Do we do a urinary test of VMA and HVA? The answer is yes. So urinary VMA, HVA will be high. HVA, VMA in the urine, these are going to be high. Okay, also in the plasma, they're also going to be high. Now, next one is over here, pheochromocytomas. We usually do not go for biopsies in pheochromocytomas because in adult patient with the sign symptoms and the findings, we can usually go for the diagnosis that this patient has pheochromocytoma. So what we do is that we directly treat the tumor by surgery. Now, over here, let me tell you this. If you are surgically resecting a pheochromocytoma, right? Before surgically removing the pheochromocytoma, do you have to, for example, the patient has pheochromocytoma for a long period of time. doesn't this mean that the patient's blood contains more epinephrine and norepinephrine than that of a normal individual? Yes or no? The answer is yes. So all of a sudden, if you get rid of the tumor that is producing the epinephrine and norepinephrine, all of a sudden, if you do this, isn't there a possibility that the patient can get life-threatening tachycardia, arrhythmia, yes or no, because of all the epinephrine, norepinephrine surge that will happen? Just give me 1 second. Okay. Okay, my apologies. Can you guys hear my voice? Yes or no? Can you guys hear my voice? Yes? Okay. So what we were talking about is resection of a pheochromocytoma. Before we resect the pheochromocytoma, do we have to make sure that the excessive epinephrine and norepinephrine in the blood, we have to make sure that they do not cause catecholamine surge. So before we resect the tumor, we have to give a drug that blocks the alpha receptors and the beta receptors, because the alpha receptors and the beta receptors are basically your sympathetic receptors. Now, the question is, which one will you give first, alpha blocker or beta blocker? The thing is, if you give a beta blocker before you give an alpha blocker, there will be excessive activity on the alpha blocker. And you know what happens when you excessively block the alpha receptors, right? This is the heart. When you, for example, this is the peripheral blood vessel. If you block the beta blocker and the alpha receptors are all available, all the epinephrine and norepinephrine will go and it will bind to the alpha receptor, resulting in vasoconstriction, excessive vasoconstriction. All this excessive vasoconstriction will do one thing, that is, it will fatally increase your afterload of the heart. So the afterload will be increased. So in order for the left ventricle to push the blood out will be very difficult. As a result, patients can get life-threatening heart failure or arrhythmia. So to achieve this, the first thing to do would be to block the alpha receptors and then to block the beta receptors. The thing is, which one will you give for blocking the alpha receptor? The thing is, we will give an irreversible alpha-1 blocker. The name of this drug is phenoxybenzamine. Phenoxybenzamine. And let me tell you this right now. This question, whether you will block beta receptor or alpha receptor, or when you do block alpha receptor, which drug will you give before you resect a pheochromocytoma, is a step 1 favorite. So it's a 5-star to a 10-star question. Have I made myself clear? Yes or no? Yes. Okay. So that's all about. Excuse me. That's all about pheochromocytomas. Let's talk about another thing over here, the thing which we have been discussing time and time again since the beginning of the lecture, that is men, right? We have been discussing men time and time again. How many types of men do we have? We have 3 types of men: men 1, men 2A, men 2B. It's time for us to figure out which men is associated with what type of tumors, which men is associated with what type of genes, and that. Okay. So for this, we will use a couple of mnemonics. Okay, the mnemonics that we will use are that of three sisters. Okay. How about three brothers, since they're all men? Okay, so three brothers. Okay, so that you do not ever forget the men diseases. So we have three brothers. Okay, so the first brother looks something like this. The first brother has a face that looks like this, lips that looks like this, eyes are normal, a nose that looks like this. Okay, a box-like face. This brother he has a wide neck. The first brother is crying. I'm going to tell you why. Okay, the first brother is crying. I'm going to tell you why. Next one is over here. The brother has a swelling in the neck. Okay, the brother has a swelling in the neck. And let me just draw some hair. Okay, so that's it. Now this picture by itself, I'm going to tell you how this will help you remember all the three diseases of men 1. This is the first brother. Okay. Now, this brother over here with the box-like face, thick lips, thick tongue, wide nose, a sort of bossing over here. Can he have a pituitary adenoma? Yes or no? The answer is yes. Okay. Pituitary adenoma. Next one is that you have to remember that the brother was crying. Why? You ask him why. Okay, so what he says is stomach pain. Basically, his stomach hurts. His stomach hurts because he has excessive amount of ulcers in his stomach. That is, he has Zollinger-Ellison syndrome. Zollinger-Ellison syndrome is due to gastrinoma, a very common pancreatic neuroendocrine tumor. So with this stomach pain and gastrinoma, you have to remember that another one is pancreatic neuroendocrine tumor. This could either be a gastrinoma, this could either be insulinoma, this could either be glucogonoma, VIPoma, but gastrinomas and all of those things, they're very important. Okay. Next one is this swelling over here. This swelling over here will help you understand that this patient is suffering from a parathyroid adenoma. So you have two choices to remember men 1. Either you remember this picture or you remember 3 P's. 3 P's. 1 P for pituitary adenoma, 1 P for pancreatic neuroendocrine tumor, another P for parathyroid adenomas. Are we clear? Yes or no? Yes. Okay. Why do we get men 1? Why? Okay. Why do we get men 1? We get men 1 because there is a deficiency or there's a problem with the tumor suppressor gene. Whenever we do not have a tumor suppressor genes are supposed to suppress the growth of tumors. When we do not have those tumors, or I mean those genes, or their absence of those genes, there is excessive production of different sorts of, or there's excessive tumors in different parts of the body. So that's the whole concept of tumor suppressor. But what is the name of the tumor suppressor gene that's absent over here? It's very simple. It's MEN1 tumor suppressor gene. Okay. And we're glad that the scientist or whoever came up with MEN1, they did not name the gene by their name, right? So if they named the gene by their name, it could be something gene, right? If I named it by myself, this would be Ferdinand Haidari gene. But I'm happy that scientists, they do not do that anymore. Okay? They started naming the gene as what it is, MEN1 tumor suppressor gene. Okay. So that's the next one is so that's the first brother. Yes. Let's talk about the second brother. The second brother does not have any coarse facial features. He's a normal young man, okay, who is studying medical like us, okay. But after studying his medical, instead of studying for USMLE, he wants to study public health. Especially, he wants to do masters in public health. Right? This is the story of the second brother. The first brother is all coarse facial structure-y, crying and everything else, but the second brother is more of in a normal scale, right? In a normal human being after finishing MBBS. Now he wants to go and study for masters in public health. Now, masters in public health, MPH. Okay. Yes, good for him. I wish I also studied public health. MPH. Okay. M for medullary thyroid carcinoma. P for pheochromocytoma. H for hyperparathyroidism. Okay. Are we clear? Yes or no? Why do we get men 2A? Because of Rett gene. Are we all clear? Yes or no? Okay. Last one, the last brother. Okay, the third brother or men 2B. Okay. Now, the third brother looks like this. Okay. 1 second. The third brother looks like this. Okay. Excuse my drawing skills. Okay. So if you guys are better at drawing, then please, you are more than welcome to make your own drawing, but this is just for your remembering purposes. Okay. So the third brother looks something like this. Okay. The third brother looks like this. Okay. Look at how big his torso and his legs are. Okay. What does this mean? Can anyone tell me what this means? When will someone look like this? Yes, very good. The third brother has a marphonoid habitus. Not only does he have a marphonoid habitus, he also has something like this. Okay. He also has swelling over here. He also has a swelling over here. So the thing is, what I'm trying to say is that not only is the third brother all tall and lanky and have a swelling in the throat, but the third brother is always anxious, and he's always nervous, and he's always tensed, and he has tremor all the time. Okay, everything is shaking all the time. Okay. So what will and how will this help us remember that the third or meant to be? So marphonoid, so a tall and lanky structure for marphonoid habitus. What else? Then the swelling on the throat for medullary thyroid carcinoma. Okay. Next one is anxiousness, tremor, tensed, anxiety for pheochromocytoma. And he has another thing over here. If you look very closely in his face, you will see that he has spots on around his lips and chins. Let me show you what I mean. What I mean is this. These are called 1 second. Let me show you a better picture. These are called mucosal neuromas, something like this. Okay. This small sort of tumor-like growth that you see in the tongues, lips, especially in the tongues. You can get a little bit of them in the buccal mucosa. You can get, they're more present in the tongue than the buccal mucosa. That's what this is called, mucosal neuroma. Okay, they're there in men 2B. Okay, this is a patient of men 2B, marfanoid habitus, medullary thyroid carcinoma will be there, pheochromocytoma. As you can see, there's this surgical mark which shows that the pheochromocytoma has been excised. The tongue has this sort of swellings. So that's it. Okay. Have I made myself clear? Yes or no? Is everyone clear? Okay. Why do we get men 2B? Because of the same gene that caused men 2A. Red gene. Okay. That's that. Now, who can tell me the structures of the brothers or directly tell me the names of the diseases? Who can tell me the names of men 1? Please say me on the chat box if you're interested. Anyone? Okay, Dr. S, thank you so much. Please unmute yourself so that everyone can hear. Okay, Dr. S is not responding, so I'll move on to Dr. V. Please unmute yourself so that everyone can hear.
Men 1,
Yes, men 1.
pancreatic endocrine tumor, and parathyroid.
Parathyroid, parathyroid adenoma.
Adenoma.
Okay. Okay. Very good. Thank you so much. And who can tell me the names of men 2A? Dr. Ellen, thank you so much. Please unmute yourself so that everyone can hear.
Okay, so men 2A is MPH, so M for medullary thyroid carcinoma, P for parathyroid pheochromocytoma.
Okay.
And H, H is the parathyroid hyperplasia.
Yes, hyperparathyroidism. Very good. Thank you.
Okay.
Thank you so much. Okay. Parathyroid hyperplasia, hyperparathyroidism, it's the same thing. So you are absolutely correct. Thank you so much. Who can tell me about the names of the diseases of men 2B? Anyone? Yes, Dr. Dahlia, thank you so much for helping us out. Please unmute yourself so that everyone can hear the names of the diseases. Okay. Okay. So Dr. Dahlia, I think it's not responding as of right now. So let me just say it. Okay. Yes. Do we have Dr. Dahlia? Yes.
Yes. It is medullary thyroid carcinoma and pheochromocytoma, and last thing is mucosal neuromas.
Okay. And do you remember the structure of the third brother? Marfanoid habitus. Do you remember? The tall and lanky structure.
Marfanoid, yeah. Marfanoid
habitus.
Yes.
Okay. Thank you so much. Now, one more thing before I move forward to the next thing. If you have a patient who comes to you with the sign symptoms of bitemporal hemianopia, headache, vomiting, abdominal pain, polyuria, depression, then sweating, palpitation. Okay, very different course of sign symptoms. Let's see if you guys can make the provisional diagnosis. What is your provisional diagnosis for this sort of clinical feature? Okay. Does anyone know the provisional diagnosis for this one? Very good. This is men 1. How? Bitemporal hemianopia, headache, vomiting. What does this indicate? This indicates pituitary tumor. There you go. Abdominal pain, polyuria, depression. What does this indicate? Hypercalcemia associated with not pancreatic. Abdominal pain, polyuria, depression. This is hypercalcemia associated with parathyroid. Very good. Sweating, palpitation associated with sudden onset of sweating, palpitation. Doesn't this sound like a hypoglycemic episode? Yes or no? This is due to an insulinoma, which is a pancreatic neuroendocrine tumor. Okay, you have another patient who comes to you with dysphagia, hoarseness, tingling sensation around the mouth, Bostick sign, Trousseau sign, anxiety, tremor, pallor, palpitation, polyuria, abdominal pain. What else? Depression. What is your diagnosis for this one? Mental. How? Dysphagia, hoarseness, tingling sensation around the mouth, Bostick sign, and everything else is for medullary thyroid carcinoma. Okay, because in calcitonin we can get hypocalcemia. Polyuria, abdominal pain, depression for which one? For hyperparathyroidism. And palpitation, pallor, tremor, anxiety for which one? Pheochromocytoma. Okay. So you do realize, right, that when you guys receive questions in your step 1 exam, they will not directly tell you that, oh, you have a patient who comes to you with a pituitary adenoma, hyperparathyroidism, and he has pancreatic endocrine hyperplasia. Would you please tell us what sort of a men this is? Okay, so this is not the type of question you'll receive in your step 1, right? What you will receive are a constellation of sign symptoms that are associated with each and every disease of the multiple endocrine neoplasia. Last but not the least, if you have another patient who comes to you with morphonoid structure, morphonoid feature, dysphagia, hoarseness, I'm sure you guys know where I'm going with this, right? Anxiety, tremor, palpitation, then obviously this is your diagnosis for men 2B. Okay, so that's it. Okay, good. So for now, we're done with multiple endocrine neoplasia. Let's move on to the next one. The next thing that I want to talk to you guys about are a couple of different sign symptoms for pancreatic tumors. Pancreatic neuroendocrine tumors. Okay. So let's talk about the tumor that will arise from alphas. Okay. If you have a patient who has an alpha cell tumor, which hormone will be overproduced? Glucagon. Very good. This is the glucagon. Okay. So whenever you have a glucagonoma, should you be hypoglycemic or hyperglycemic? Hyperglycemic. Very good. Okay. Next one is if you are hyperglycemic, do you have high amount of blood glucose? The high amount of blood glucose in your blood, will it increase your appetite or decrease your appetite? Decrease your appetite. So would you get weight loss or weight gain? Weight loss. Next one. The high amount of blood glucose in your blood, can it act as a very potent environment for growth of different sorts of bacteria? The answer is yes. If that is, then can skin be the #1 organ that could be affected by dermatitis? Yes. So what I'm talking about is necrolytic migratory erythema. Okay. Next thing is if you have a high amount of blood glucose, especially if you're a woman, and if you have a high amount of blood glucose after 30, let's say, isn't it a possibility if also the woman is a smoker? Or let's say the woman is not a smoker, or let's not even use genders for this, because it could go either way. So the reason why I said women is because in women, this is more common. But let's not genderize this whole thing. Let's just talk about what would happen. Let's say if there's a high amount of blood glucose in the blood, will this act as a very potent area for depositions of lipids and fats? Yes or no? The answer is yes. And if that's the thing, then isn't there a possibility that we can get vessel thrombosis? Yes or no? DVT. Right? Vessel thrombosis. Next one, glucose. Is glucose an osmotically active substance? Yes or no? Yes. So will it cause diarrhea? The high amount of glucose in the bowel can cause osmotic diarrhea. Patients can get diarrhea. Okay. Okay. Next one is all of this can cause depression. High amount of glucose has also been linked to cause depression. Now let me rephrase the first three letters, the first two words. The first one was hyperglycemia. Another word for hyperglycemia is diabetogenic. Not diabetes, diabetogenic. Patients will be diabetogenic, meaning they will have an increased risk of developing diabetes, but they might or might not develop diabetes. Next one is weight loss or declining weight. Another one is dermatitis or necrolytic migratory erythema. So glucagonoma is associated with all the D symptoms. Are we clear, everyone? Yes or no? Diabetogenic, declining weight, dermatitis, DVT, depression. Okay, let's talk about another type of a neuroendocrine tumor. This tumor will arise now from the beta cell. So what is the name of the hormone that will be overproduced? Obviously, the hormone is insulin. If there's overproduction of insulin, do we get hypoglycemia or hyperglycemia? Depression. Why depression? Because high hyperglycemia has been linked to decreased metabolic activity of the brain, because the brain already has glucose, so it doesn't feel the need to function as much. So decreased activity of the brain has been linked with depression. That's that. That's a theory. Next one. Hypoglycemia or hyper. The answer is high insulin will cause hypoglycemia. Okay. Now, the insulin, the sign symptoms of insulin, whenever we get hypoglycemia, do we get sympathetic overdose or parasympathetic overdose? The answer is we get sympathetic, not parasympathetic. Hypoglycemia. Why do we get sympathetic overdose? Okay, let me tell you this so that you guys will never forget this. Once again, the brain survives on a couple of things. This looks like a coffee bean. Okay, let me just draw a brain one more time. Okay. Still not sure if this looks like a brain or not, but no problem. Brain depends on blood, oxygen, glucose. Very simple. Whenever blood glucose level falls, brain cannot function. Brain sends out signal, especially which part of the brain? Hypothalamus sends out signal to the sympathetic activity to cause fight or flight. Whenever we have sympathetic activity in the body, we get hepatic gluconeogenesis. Hepatic gluconeogenesis that increases the glucose level by breaking down amino acids and lipids. So this is the biochemical pathway. So all of this is to let you know that hypoglycemia will cause sympathetic activity. Are we clear? Yes or no? Okay. Next one is Next one is, so we have hypoglycemia, which are the signs symptoms of sympathetic overdose. So patients will get diaphoresis, tachycardia, syncope, and those things. Blurry visions can also happen, right? And over here, what will happen is that the patients, they will have increase of both insulin and C-peptide. Why? Because insulin is not secreted by itself. Whenever we have a tumor of the beta cells, insulin and C-peptide will be secreted together. As simple as that. Okay. Next one is, I want to talk about another sort of a thing. There's this thing which comes as a sort of question in the exam. The way that they try to describe an insulinoma or a hypoglycemic episode is by describing a triad called the Whipple's triad. What is the Whipple's triad? Whipple's triad is basically hypoglycemia, okay, and sign symptoms of hypoglycemia together, meaning sympathetic activity. So not only will the blood glucose be low, the low blood glucose will also show symptoms, because a lot of hypoglycemic patients, they usually do not have very distinctive sympathetic symptoms. But in this case of an insulinoma, there will be a Whipple's triad sort of an episode where patients will have not only hypoglycemia, they will have severe hypoglycemia to the point that their symptoms are showing as a form of sympathetic activity. As a result, whenever we try to treat the symptoms, either by prescribing IV glucose or by anything else, there is complete resolution of sign symptoms. So to rephrase one more time, what is Whipple's triad? Whipple's triad is a triad of symptoms where patients have hypoglycemia, sign symptoms of hypoglycemia, and complete resolution of the sign symptoms of hypoglycemia whenever we give IV glucose. When all of these three things are mentioned or are present at the same time, this is called a Whipple's triad, and this immediately indicates that the patient is suffering from a possible insulinoma. Okay, are we clear, yes or no? Everyone? Okay, now there's another type of tumor that we get, that is whether the delta cell, that is a somatostatinoma. I personally do not want to talk about somatostatinoma because it's not very high yield. What I do want to talk about is, I do want to talk about VIPoma. VIPoma is a vasoactive intestinal peptide, VIPoma. It's also a sort of pancreatic neuroendocrine tumor. The signs and symptoms of VIPoma. We'll talk about this in details in GI pathology, but for now, just try to remember that the signs and symptoms are WDHA. WD stands for watery diarrhea. H stands for hypokalemia, and A stands for achlorhydria, meaning absence of gastric acid production. Achlorhydria, or decreased gastric acid production, because VIP inhibits the production of gastric, inhibits the production of gastrin by the G cells. So that's that. Okay, another type of tumor I want to talk about is a gastrinoma, another type of a pancreatic neuroendocrine tumor. A gastrinoma is basically a gastrin secreting tumor that causes excessive sort of production of gastrin. Now, gastrin stimulates the G cells to convert to produce an increased amount of hydrochloric acid. So whenever we have this sort of gastrinoma, we get a disease called Zollinger-Ellison syndrome. Okay, so Zollinger-Ellison syndrome is basically the name for the constellation of sign symptom that happens whenever we have gastrinoma. So what are the sign symptoms? First and foremost, patients have severe abdominal pain. That makes sense because we have ulcers everywhere, not only in the duodenum, we get them in the jejunum, and we get them in the ileum. So whenever you receive a question in your step 1 exam about the ulcers and then gastroduodenal you see a lot of different sorts of ulcers in the duodenum, jejunum, and ileum. If to come up with the conclusion that the patient is suffering from the Zollinger-Ellison syndrome. So first and foremost, the patient will have abdominal pain. Next thing is, all of these ulcers, will this increase absorption of the nutrients or decrease absorption of the nutrients? Last answers, please. They will decrease absorption of the nutrients. If there's decreased absorption of the nutrients, can they act as osmotically active substances? The answer is yes. Can they cause diarrhea? The answer is yes. Patients, can they have deficiencies of different sorts of vitamins and minerals? Yes, the answer is yes. Okay. So you can get vitamin A, B, C, D, E, F, G, H, I, J, K, L deficiency, as many as vitamin deficiencies as you want. Okay. So that's that. Now, next one is, how do you basically try to see if, okay, you guys do understand, right, that there are no vitamins called with F, vitamin F, G, H. I was just joking. Okay. F, E, F, G, H, there's E, but there's, after E, it kind of stops. So vitamin F, vitamin G, vitamin H are not there. Okay. Now, next one is the secretin stimulation test, which we can do. Secretin will, in a normal human who does not have a gastrinoma, if you give them secretin, that's another sort of a gastric hormone, secretin will decrease gastrin. But if there's a gastrin producing tumor, do you really think that secretin will be able to decrease the production of gastrin? The answer is no. So in a patient with secretin stimulation test in gastrinoma, the test will be negative. Okay. Am I clear? Yes or no? Everyone? Okay. Okay. Before I move on to the last topic over here, a quick discussion. You have a patient who comes to you with signs and symptoms of anxiety, tremor, palpitation, diaphoresis. You see that the blood glucose is 50. You give IV glucose immediately to save the patient. And there's instantaneous resolution of the signs and symptoms. What is your diagnosis? Very good. You have another patient who comes to you with hyperglycemia, decreased appetite, long-term depression. Patient has diarrhea. Patient has ulcers in the skin. This is very good. Glucose normal. You have another patient who comes to you with watery diarrhea. Along with this, you see the patient has muscle aches. The patient has a history of cardiac problems, cardiac arrhythmia, and the patient has recurrent abdominal pain. What is your diagnosis? Watery diarrhea, muscle aches, and abdominal pain. VIPoma. Very good. Okay. You have another patient who comes to you with severe abdominal pain and diarrhea, and in a gastroduodenal jejunoscopy, you see multiple ulcers in the duodenum and the jejunum. What is your diagnosis? Why muscle aches? Muscle aches for hypokalemia. Okay. Now, last one. Last one is, you have another sort of presentation where you have certain cells, or certain neuroendocrine cells that are mostly present in this portion of the GI tract. This is your, okay. What is the name of this organ over here, which some of us have to get rid of? The name of this organ. What is the name of this organ? Which some of us have to get rid of? Yes, there you go. Appendix. What is the name of the syndrome that arises due to an abnormality of a neuroendocrine cell that resides in the appendix? Can anyone tell me the name of the syndrome? Okay, the name of the syndrome that arises due to a sort of neuroendocrine cell that resides in the appendix. The name of the syndrome is carcinoid syndrome. Okay, very good. Carcinoid syndrome. Carcinoid syndromes are basically neuroendocrine tumors that have the habit of producing excessive amount of serotonin, or better yet, we call this as 5-hydroxy-indoloacetic acid, 5-HIAA. Now, in order for 5-hydroxy-indoloacetic acid, or we can also call this 5-hydroxytryptamine. Okay. Now, in order for this carcinoid syndrome to start producing the sign symptoms of serotonin surge or excessive serotonin, first and foremost, the tumor has to be progressive enough to metastasize to the liver. Okay, if the tumor is not progressive, if it does not metastasize to the liver, it will not produce the sign symptoms of serotonin surge. So my next question is, if there is a patient of carcinoid syndrome who is showing sign symptoms of carcinoid syndrome, doesn't this already mean that the patient has metastasis to the liver? Yes or no? The answer is yes. Next one is if this is the heart, right? And over here you have lungs. Okay, this is the right side, this is the left side. So the serotonin, excessive serotonin, will come through the inferior vena cava to the right atrium. From the right atrium, it will go to the right ventricle. From the right ventricle, it will go to the lungs. Or from the lungs, it will come back to the left atrium, left ventricle, and then it will go to the aorta. The question is, in which side of the heart will the serotonin produce more symptoms? The answer is, it will be on the right side of the heart. It will be on the right side of the heart. So why will it produce more symptoms on the right? First and foremost, the first reason why it will produce more symptoms on the right is because over here you have the tricuspid valve, and this is the first valve to receive the excessive serotonin. So all of this excessive serotonin in the tricuspid valve will cause damage to the chorda tendineae, and this can cause severe tricuspid regurgitation. But when the serotonin goes from the right atrium to the right ventricle, after damaging the tricuspid valve, it goes to the lungs. In the lungs, we have an enzyme called monoamine oxidase. Monoamine oxidase will break down the serotonin. So if they are broken down in the lungs, will we have serotonin coming back as much on the left side of the heart? The answer is no. As a result, sign symptoms will be there on the right side, not on the left side. So what are the sign symptoms? So patients can come to you with flushing due to serotonin, which can cause vasodilatation, wheezing because serotonin causes bronchospasm, then palpitation, then jugular venous distension due to tricuspid regurgitation, then diarrhea. All of these are the sign symptoms of serotonin due to carcinoid syndrome. What is the treatment? Simple: resection followed by octreotide. So surgery and octreotide. Octreotide is a somatostatin analog that will decrease the production of carcinoid syndrome. Okay. Are we clear, everyone? Yes or no? Are we clear? Yes. Okay, good. Okay, very good. Now, before I do this, before I move on to AMBOSS, let me just underline the high yield points from where questions will be received. Number one, pheochromocytoma. Please put your stars for pheochromocytoma, very high yield. Causes are important. Where are they derived from? Chromaffin cells that are neural crest. Where do they reside? They reside in the adrenal medulla. These are the genes that are associated with pheochromocytoma. This is high yield. The rule of 10 is not important, except I just want to bring one thing to your attention, that 10% can be calcific. That's that. Symptoms are that of a catecholamine surge. Patients will get hypertension, headache, perspiration, palpitation, pallor. I discussed all of these symptoms, so move forward. Some patients can also have sign symptoms of polycythemia because of excessive production of not only epinephrine and norepinephrine, but also of erythropoietin. But since I have not received a question about this in the step one banks, So I will use my blue pen for this one because this is not a question, could be a possible question in the future, I'm not sure. Highly doubt this will be a question though. Findings is you will find increased catecholamines, HbA, DMA in the urine and plasma, that's one. Treatment is very simple, surgery, but before surgery, we have to give an alpha blocker, especially phenoxybenzamine. And once all the alpha receptors are blocked, then we can give a beta blocker. Then after blocking alpha and beta, then you can go for surgery. Okay, not before that. Please do not forget the name of this drug. This is exceptionally high yield. Next one is men. Everything about men is excessively high yield. Okay, all the men are dominant. That means it's all of them is an autosomal dominant disease. So if any of the parents have any of the men, then the child, there's a 50% chance that either one out of two child might have the sign symptoms. Men one, I'm not gonna underline anything because everything is important. Same goes for men 2A and men 2B. I'm pretty sure you guys know by now what sort of questions you guys will receive. Please try to remember that you are not only, you will not receive the writings of pituitary tumor. They will not tell you that the question that the patient comes to you with pituitary tumor. What they will try to tell you are the signs, symptoms associated with pituitary tumor. So please keep that in mind. You will get headache, nausea, vomiting, that's that. Zollinger-Ellison syndrome, you'll get pain. Insulinoma, you'll get Whipple's triad. Diapioma, you'll get WDHA. Glucogonomas, you'll get 6Ds. Parathyroid adenomas, you get abdominal pain, abdominal groans, renal stones, polyuria, depression. Parathyroid hyperplasia for the same thing, hypercalcemia. So you get, once again, abdominal pain, polyuria. Medullary thyroid carcinomas, you can get compressive sign symptoms, dysphagia. You can get calcitonin, which can cause hypocalcemia. So that's that. Pheochromocytomas, you will get anxiety, tremor, pallor, tachycardia, perspiration. So you probably get the idea of how the questions will be structured. So that's that. Let's talk about pancreatic islet tumors. First of all, you have insulinomas, where this is due to the tumor of pancreatic beta cells. Whipple's triad is high yield for the exam. Okay. Then over here, what else? You have patients have decreased blood glucose and increased C-peptides. That is high yield. Treatment is by surgical resection. Glucogonomas are all the 6Ds. Glucogonoma is important. There are multiple questions regarding glucogonoma. Treatment is via somatostatin analog and surgical resection. Next one is somatostatinoma. This is not very high yield, so I'm going to use my blue pen. It's a tumor. It's a tumor of the pancreatic delta cells, which produces somatostatin. Somatostatin will cause, always remember, somatostatin will cause stasis of all hormones. So it will decrease the secretion of secretin, cholecystokinin, glucagon, insulin, gastrin, GIP. Patients may get gallstones, steatorrhea, achlorhydria, but it's not high yield. Treatment is surgical resection and somatostatin analogs. Okay, not high yield. Carcinoid tumors. Carcinoid tumors are high yield. Sorry, my apologies. Carcinoid tumors are high yield. They arise from the neuroendocrine tumors, especially from the intestines, meaning the appendix, or some of them could also be in the lungs. But intestines are more common. Questions are also associated with that. Neuroendocrine tumors secrete 5-hydroxytryptamine, which undergoes hepatic first-pass metabolism, and then they are broken down by the lungs. If the 5-hydroxytryptamine reaches the systemic circulation, carcinoid tumor after liver metastasis, this is very important, meaning that if they are present in the system, then that must mean there has already been a liver metastasis. Patients will get flushing, wheezing, right-sided valvular disease. That's it. Histology is not important for carcinoid syndrome, but if you can remember one thing, try to remember that in neuroblastoma, we got the rosettes, which was also a neuroendocrine tumor. So for the histology of this one, we will also get rosettes. Okay, let me use my blue pen for this. They did not ask you the histology of carcinoid syndrome, but try to remember if you can. If you can't, no problem. Zollinger-Ellison syndrome is a gastro-secreting tumor of the duodenum and pancreas. There is excessive acid hypersecretion in the duodenum and jejunum, presence with abdominal pain, and patients have a positive secretin stimulation test, meaning that stimulation by secretin will not be able to suppress gastric. So that's that. Zollinger-Ellison syndrome is very high yield. Okay. It's very heavily associated with MEN1. Okay, are we clear, everyone? Yes or no? VIPoma is not over here. VIPoma is in gastroenterology. Okay? It's in the GI lectures, not here. If you want, you can write down over here in your book if you want to remember VIPoma. Just write down VIPoma and write down WDHA. Watery diarrhea, hyperkalemia, acrohydria. Which sign symptom do you want to know? Okay. Okay. All right. Okay. So with that being said, congratulations. We are done with endocrine, physiology, anatomy, and biology, and pathology. Okay, so we didn't do bad for the first couple of classes. Eventually, we'll pick up the lectures even more, and we'll even go faster than this. But is the pace of the lecture okay? Okay, so let me ask you a couple of questions to sort of modify my lecture in the future if I need to, because different students and different batches are different, so feedbacks are really important. Now, I want to ask you a couple of questions regarding the lecture over here. First of all, is the pace of the lecture okay? Is it slow or is it fast? So it's not slow, not fast. Okay, good. Next one is, do you guys understand my handwriting enough? Okay. Okay, good. If not, then I would put an emphasis. Since you guys do understand my handwriting, I'm going to keep my handwriting as bad as it is. Okay, now let's move forward. Do you guys like lectures after discussion in the blank page or directly from first aid? Which one? Okay, I personally like this. Let me tell you why discussions in the blank. Yes, discussions in the blank page are important before we jump to first aid, because a lot of mnemonics go in the blank pages and the different things, and it allows me to think more about the different sorts of associations of step 1 and step 2 CK questions. And okay, so since you guys like the blank page, thank you so much. I also want to stick to this method. So blank page, and then I'll tell you what to do for first aid. Okay, and I just want to mention one thing over here very quickly. When I take lectures in the blank page, I usually try to provide the lectures from my own knowledge, from what I have, from what I remember. Because usually what I do is before I take your lecture, I usually revise the lectures, usually in the early morning or late night, so that I'm aware of the topics I should be talking about. So since I'm taking lectures in the blank page, there is a very slight chance, or there's a very slight possibility that I might say something that could be wrong or could be on the wrong side of the lectures. But I usually try to correct myself instantaneously. So I just want to apologize beforehand if I do give out any wrong information, but hopefully I will not do that, because even after our discussion, we always go back to first aid and we try to see if the blank page and everything, if it matches or not, and it always will. But there is a possibility that there is a, for example, 1% chance that some of the discussions in the blank page might be a little bit out of context. So if you guys ever think that this doesn't really go or there's anything else, the whole reason why I'm telling you this is please do not be afraid, or please do not hesitate to question the lecture, or please do not hesitate to question whether if it's right or wrong, because at the end of the day, I'm also human, so there's a possibility that since I'm conducting the lectures, there's a possibility that you and I can both experience a little bit of human errors. Okay, so that's it. Now, is it okay if I keep the lecture up to here for today? Because we do not have a lot of context left for the free classes. Tomorrow, we will be finishing endocrine pharmacology. And we will also be doing extra questions, 20 questions. Since we didn't do questions today, we'll do 10 more questions tomorrow, because I know it's already pretty late. It's 1:11. And that's that. Another reason is I also want to give you guys some space to sort of study the material which we have learned in the last couple of days. That's that. Keep in mind that tomorrow is possibly the last free class. Okay, so we will be talking about our transactions and everything else. And we are not taking a very lengthy classes in the free lectures, but once we start our subscriptions and we take subscribed lectures, classes will be a bit more lengthier. Classes will be a bit more fun than it is, more or less. The reason being is because we will be incorporating a lot of different other resources. We will be incorporating physio, MBOSS as usual, and a couple of videos here and there, which I have collected for the course. And also step 2 CK informations time and time again. So that's that. Already, as a matter of fact, we have close to around 18 students who have subscribed to our lectures, and they have basically tried to book their spots in the lectures, because we only have 25 seats available. So tomorrow I'll tell you exactly what you need to do in order to subscribe to the lectures from next week, Monday. So we're expecting that over the course of this weekend, everyone will be able to complete their transactions. If you guys are still wondering how much do we charge for the transactions, we charge $1 per hour, and we take 100 hours per month. So our total cost comes up to $100 per month. That's very simple. And I highly doubt that you guys will find tutors which are less than $1, right? So this is the minimum amount which I will be charging everyone. So that's it. How to book. So tomorrow I'll tell you how you can book. I'll tell you the methods and the options of the ways we can complete the transactions. We use a couple of methods for completing the transactions. We use PayPal. We use Venmo. We use Western Union. We use direct bank-to-bank transfers. Okay, so whichever you guys are comfortable with, you guys can choose and complete the transaction accordingly. Okay. Does anyone else have any questions? Yes or no? No. Good, very good. Okay. So that's that. Now, the thing is, we will also be starting our step 2 CK class at 2:30 p.m. today. So if you guys are free, if you guys have the time to join the step 2 CK class, you're more than welcome to do so. As of today, it's still a free class, and we are going to begin GI tract and GI pathologies and everything else. So that's what it is. And the second thing is, if you guys have friends who need help for USMLE step 1, step 2 CK, please do not hesitate to ask them to come and join us. And the third thing that I wanted to talk about is about the lecture from yesterday. The link for the lecture from yesterday is over here. So let me just share this with everyone so that you guys know where to go and see the lecture recording. Okay. And that's that. Okay, so thank you so much for joining the lecture. Hope you guys have a very good day. If you guys have questions, please send us an email and we'll get back to you. And if all goes well, I'll see you guys tomorrow at 9:30 a.m. and we will finish endocrinology. Okay. Thank you so much and have a great day. Bye-bye.